Hello, Sharon. Were you trying to speak something?
No, no.
Okay. All right, then we'll continue with our CNS pharmacology, and then we'll start with CVS. All right, so let's just continue. CNS pharmacology. As I told you, epilepsy they don't ask like epilepsy topic they don't ask personally regarding the type of seizures, but they do ask about the anti-epileptic drug. Okay, so drugs are important, but if you don't remember the features of the seizures, how you will be able to do the drug? Okay, so just remember one line in all the types of seizures that we have seen. Like questions based on seizure won't be asked, but questions from the anti-epileptic drug will be asked, and they will say that it was a focal seizure, tonic-clonic seizure. So what is the drug of choice for a tonic-clonic seizure? They will explain you the seizure, and then they will say which drug will you prescribe to the patient. Okay. So most commonly the questions will be based on valproate. Second one will be etoxaximide. Third, benzodiazepine and carbamazepine. And the last one is they like to ask about lamotrigine and levetiracetam. Why? Because they are the drug of choice in pregnant females. Okay, so these five drugs are very important. Rest all you can just give a read. I'll tell you. Phenytoin they don't ask you the use, but they ask the side effects. Okay, so let's just discuss them one by one. The first is benzodiazepine. You should remember the mechanism for all of them because they will be focusing more on mechanism and side effects over here rather than just focusing on the types of seizures. Okay, so mechanism and side effects. Side effects, may I will mark you what you need to remember, but mechanism you have to remember for sure because the drug they won't mention the drug. They will ask you what is the mechanism of treatment over here. So mechanism of treatment will be the same as the mechanism of drug. Okay, so don't get confused over here. Okay, so let's come to the benzodiazepine increasing GABA action. So adverse effect here it will be sedation and respiratory depression. Okay, it is also used for eclampsia seizures. So benzodiazepines in detail we will do later. Coming to carbamazepine, remember the mechanism, and yeah, the most commonly asked adverse effect about this is diplopia. Then you have agranulocytosis. Then they are teratogenic and SIADH and SJS. Okay, SIADH and HJS, and I told you when you're solving UL, you should remember the induction of cytochrome P450, the induction and inhibitors. It is given in the pharma section also in the latest edition of first aid. In 2020, it wasn't given. So if you have watched the pharma video, I have mentioned you there also key inducers and inhibitors of CYP450 is very important. You should mark them up. Okay, so carbamazepine is also inducer of cytochrome P450. All right, so these five: diplopia, agranulocytosis, teratogenesis, SIADS, and HGS. These are very important. First line for trigeminal neuralgia, we discussed in the trigeminal neuralgia, shooting like pain while eating, chewing, everything. So they will ask you the drug of choice, the treatment. Okay, so you should remember trigeminal neuralgia. Coming to etoxaximide always used in absence seizures. It is never used anywhere else. Okay. Absence seizures का अगर case history आया, the case history will be simple. A child who is sitting at you sitting at you blank. Okay. You are talking to a child. You are asking the child, but child isn't knowing anything. He is just sitting blank like for 1 or 2 minutes, and after that suddenly there will be a blinking of the eye. Okay. The same case will be presented to you in the question. You should know कि yeah, child is sitting blank. The answer is absence seizures and drug of choice is etoxaximide. Alright. So you should remember the mechanism as well. So let's just see the side effect. There will be GI distress, headache, itching, and HGS. So see what is important here is I'll let you know. GI distress is important and HGS is important. Okay, these both are very important. That's all you can pick it out. But HGS and GI distress very important. Alright, coming to gabapentin, primarily inhibit the mechanism is important. And see, gabapentin they won't ask you it is anti-seizure medication or not. Gabapentin they will ask you for peripheral neuropathy. Okay, and it is there in UL, so you must have come across this. So gabapentin is used for peripheral neuropathy. And guys, like in CNS also, if you are weak in pharma, if you feel that you are not good in pharma in CNS also, you can always refer sketchy pharma. Okay, so I told you before also sketchy pharma CNS में antimicrobials में, and in one more thing I said to refer sketchy pharma. What was that? I think Hemat हो गया, GIT हो गया, Endo हो गया. Okay, I don't remember now. But CNS and antimicrobials के लिए sketchy pharma is must. Okay, if you are not able to remember from your source. Coming ahead, we have lamotrigine and levetiracetam. We will be doing that together because the mechanism are though the mechanism are different. But one thing is that you need to remember here is both of them are used in pregnant females. Second, both of them can be used in elder patients because they both are safe. Okay, so pregnant females में अगर they are asking you about anti-epileptic drug of choice like anti-diabetic of choice. So you should be knowing lamotrigine or levetiracetam. They are the ones with very not dangerous side effects. So they can be given anytime. All right. So let's just see. Adjust to हो गई. And what is in the levetiracetam we have neuropsychiatric symptoms. Okay. That's all you can see headache, fatigue. Here also you can be right headache, fatigue. Okay. Levetiracetam and lamotrigine ka they won't ask you side effect. They will focus on where it is used. So if there is epileptic or seizures in pregnant female, think about levetiracetam and lamotrigine. And another thing is if the case is giving you about the old patient, so they will mention you a 60-year-old patient came to you and valproate or some other anti-epileptic was given. There were so many side effects he wasn't able to tolerate it. Now what you will give to the patient? So your answer will be lamotrigine or levetiracetam, whatever is given in the option. All right. So this is how the questions will be framed to you. Coming to phenobarbital again GABA action. We will do this in detail more along with the benzodiazepine later. Coming to phenytoin and phosphoenolitoin, remember the mechanism, and yeah, so many side effects here are asked in phenytoin. One by one, we will see them. First one will be it is inducer of cytochrome P450. Okay, hirsutism is very important. Enlarged gums is very important. Teratogenic very important, and inhibited folate absorption is very important. Dress syndrome is very important. Okay, so these 5 6 symptoms are very important, and this in the UL you can see enlarged gums पे काफी सवाल आए. There are so many questions on the enlarged gums. There is a problem in the gums after giving an anti-epileptic. Okay, so enlarged gums पे काफी सवाल आया. Hirsutism पे भी काफी सवाल आया. All right, so that's all you can just see. See, Dress syndrome है. So how the question will be presented to you? Dress syndrome will say they will say there is increase in eosinophils. Okay, there is increase in eosinophils. So this is how Rett syndrome will be given to you. All right. So eosinophils increase after taking any anti-epileptic. Think about phenytoin. All right. So that's it. Let's move towards topiramate. Remember the mechanism, and here you have to remember one thing: it will cause weight loss, kidney stone, and weight loss. So any drug that is causing weight loss is topiramate. All right, any antileptic that is causing weight loss is topiramate. And another thing is there is speech difficulty. So these three are very important: kidney stone, skinny, and speech difficulties. All right. Moving ahead, we have valproate, most important and most commonly asked question. Okay. Remember the mechanism, and yeah, you have to remember alopecia, liver damage, pancreatitis, very important. So many questions have been asked. P450 inhibition, obesity, teratogenic, and GI distress. So all of them very important. So many questions are there on valproate. And see guys, if you are confused, कि sometimes they might ask you some seizure is occurring in the patient, and if you are confused कि कौन सा drug दे, always take two drugs in the option valproate or phenytoin. ठीक है, ये दोनों ड्रग्स को आपको फर्स्ट प्रायोरिटी देना है. मोस्ट ऑफ द टाइम वालप्रेट ही दिया जाता है, एंड सेकंड इज फिनाइटाइन. So if you are confused, if no particular case has been mentioned or special circumstances has been mentioned, like a child or a pregnant or older female or some particular side effect has been given, then like if nothing has been given, you should always go for valproate or phenytoin. Okay, so just make sure you know this. Coming to vigabatrin, mechanism is important, permanent visual loss, only visual loss is important. Alright, so ये सारे हैं आपके anti epileptic drugs, and this is very very good, and they have given this in a very concise way. बाकी सारी books में आप देखोगे, so there is so much info you need to get from. And yeah, CNS pharma, if you are not able to do properly, sketchy pharma is a good resource to go for. Alright, so let's just move ahead. See, they have given everything, the mechanism and everything over here, so just have a look over here. Okay, coming to barbiturates and benzodiazepines, as I told you, we will be discussing them separately. So let's just see what we'll be doing here. So yeah, barbiturate, barbitals, all the barbitals. Okay, so let's just see mechanism. Facilitate GABA action by increasing duration of chlorine, and in the benzodiazepine there is a frequency of fluorine. Okay, guys, this is very important. This is very important because you will be confused between benzodiazepines and barbiturates. They will give you the side effects of the drug, and then you have to pick out what is the actual drug they are given, whether they give barbiturate or they give benzodiazepine. All right. So remember this mechanism, duration, and frequency. And Sketchy Medical has given so beautiful explanation regarding this. You will never forget it. Okay. So let's just move. Clinical use: anxiety, seizures, insomnia, induction of anesthesia, and here we will be having anxiety, panic disorders, toxicity. There are so many uses. Okay, so uses पे they won't be like uses पे इतना ज़्यादा फर्क नहीं पड़ेगा. But one thing I want you to know is that's it. Yeah, it is a benzodiazepines are the first line in psychotic symptoms in alcoholic. Okay, this is very important. Yeah, you should avoid benzodiazepine in elderly. Another important point is, yeah, benzodiazepine can cause anterograde amnesia. All right, and one important thing over here is, okay. So now in barbiturate, uh, there is one relation with thiopental. Okay, thiopental is an anesthetic drug. तो thiopental के साथ एक relation है. So you know what happens is the thiopental का जो absorption होता है, it actually decreases due to redistribution in body, mostly in skeletal tissue and adipose tissue. Okay, This is important because in NBME so many questions are there. In U World also I think they have one or two questions. So this line is very important. आपको आएगा thiopental और barbiturates का relation आएगा and then they will ask you what is the problem occurring. So decrease in absorption due to redistribution to fats and skeletal tissue. Okay, this is very important. You must have seen this in U World. So let's just see on the adverse effect over here. Respiratory and cardiovascular depression, very important. CNS depression, dependence. Okay, so this is very important. And in the benzodiazepines, we have dependence, additive CNS depression with alcohol and barbiturates, less risk of respiratory depression and coma than barbiturates. So this is how you will be distinguishing. The first point is barbiturates have more CNS and CVS depression. Depression. Okay, and that's it for benzodiazepine and barbiturate. But see guys, uh, like ये जो clinical use and adverse effects है ना, the sketchy form has explained so good that उसके अलावा कुछ करने की जरूरत ही नहीं पड़ेगी. So I would highly recommend you at least barbiturates और benzodiazepines का देख लो sketchy form. It will be very helpful to you. All right, and see one important line I forgot over here. Lorazepam, oxazepam, and temazepam can be used for those with liver disease who drink a lot due to minimal first-pass metabolism. Okay, this is the reasoning why it can be taken because of minimal first-pass metabolism. All right, that's it. Okay, इतना याद रखना frequency and duration. Frequency and duration is very important because they will ask you for sure. This question is going to come. All right. Insomnia therapy. Now for insomnia therapy, first one will be jet drugs. Non-benzodiazepine hypnotics are jet drugs. Okay. Why jet drugs? Because the name starts with jet, zolpidem, zaleplon and esogipiplon. Okay. So GABA receptor है. Attacks, adverse effect, you don't have to focus more over here on adverse effect. It is simple. Ataxia, headaches and confusion. Now see, in the CNS drugs, headache and confusion will be present in all. Okay, it is a common symptom and it will be present in all. So headache or confusion के basis पे आप you can't identify which drug is that. Okay, so let's just see कि इसमें और क्या कर सकते हैं. Short duration due to rapid metabolism by liver enzyme, effects reversed by flumazenil. Okay, and decrease in dependency risk and decrease in sleep cycle disturbance. Now they ask you here one question. ये जो भी drugs है ना insomnia के, उसमें they will ask you one reasoning question. Why instead of benzodiazepines and barbiturates we prefer Z drugs or other drugs? Okay, because they decrease dependence, there is decrease in sleep cycle disturbance, and there will be decrease in confusion effects. Okay, this is very important. This is the reason elderly may we don't give benzodiazepine nor we give barbiturates. We only give these drugs. ओके, तो ये जेट ड्रग्स है, ये आपको नाम याद रखने हैं. अनदर इज सुवोरेक्सान एंड रामल्टियन, व्हिच इज ऑल आर वेरी इंपॉर्टेंट. सुवोरेक्सान का यू शुड रिमेंबर दिस मैकेनिज्म, यू वर्ल्ड में है 2 to 3 क्वेश्चन आता है. रामल्टियन पूछा नहीं है बट कीप दिस इन माइंड. ओके, सो वही सुवोरेक्सान में सीएनएस डिप्रेशन हेडेक वही सब सेम चीज है एंड नॉट रिकमेंडेड इन पेशेंट विद लिवर डिजीज. लिवर डिजीज के साथ नहीं दे सकते. Okay, Rameltion, they have never asked, but they have asked this question. Instead of benzodiazepine and barbiturates, which drug can we prefer in old patients? And in one of the options, Rameltion was given, and that was the answer. Okay, so mechanism देख लेना, melatonin and orexin, ये important है. All right. Coming to triptan, triptans are 5-HT agonists, inhibit trigeminal nerve activation, prevent vasoactive peptide release, induce vasoconstriction. These all are the pathogenesis for migraine. Okay, so migraine में ट्रिप्टान देते हैं हम. Acute migraine is very important. Okay, that's it, nothing else. Okay, let's move ahead. We have Parkinson disease therapy. Okay, now this is high yield. Why high yield? First main point, you have to remember the strategy. Okay, you have to remember the strategy. Parkinson's may they will focus less on side effects and focus more on mechanism of action. And in mechanism of action, they will focus on this strategy one, because they will give you the drug and then they will ask you what it is doing, increasing dopa availability or increasing dopamine availability, or they prevent dopamine breakdown, something like that. Okay, so this is very important. ये strategy याद कर लेना. Now let's move on to important point that we need to remember here. So ये आपके ड्रग के नाम आपको याद रखने हैं. बट या आई टोल्ड यू बिफोर कि डोपामिन एगोनिस्ट जो होते हैं, जो पार्किंसन में यूज करते हैं, दे कैन कॉज गैम्बलिंग एज अ साइड इफेक्ट. Okay, they can cause gambling as a side effect, so you have to use with caution over here. Okay, coming to dopamine availability, amantadine, remember the drug name, increase in dopamine release and decrease in dopamine reuptake. This is also very important. Instead of this, they will give you this. Okay, so make sure you know them. All right, toxicity कोई मतलब नहीं है. Yeah, livedo reticularis is important. I hope you know what is livedo reticularis. जो बॉडी होगी ना आपकी लेग्स एंड स्किन, उसमें देयर विल बी नेट लाइक डिस्ट्रीब्यूशन. ओके, इफ दिस इज योर लेग, ओके, देन इट विल बी नेट लाइक डिस्ट्रीब्यूशन, ऐसा honeycomb distribution all over the skin. Okay, so that is what known as livedo reticularis. It is easily distinguishable and can be easily seen. Okay, coming to the next, increase in dopa availability. Agents prevent peripheral L-dopa degradation, increase in L-dopa entering CNS, increase in central L-dopa available for conversion to dopamine. Remember this line. Alright. So levodopa, carbidopa. Why they are used together? Carbidopa blocks peripheral conversion of levodopa to dopamine by inhibiting dopa carboxylase. Also reduces the adverse effects of peripheral L-dopa conversion into this. So this line is very important. This कि ये दोनों को साथ यूज करने से there is one important point that the UL has to ask is what are the adverse effects that will be prevented when they use together. So nausea and vomiting. In one question is there in UL and one question is there in NBME. Okay, so this is important. Levodopa, carbidopa, levodopa, carbidopa का आप अच्छे से समझ लो. Alright, the mechanism is important. Okay, यहाँ पे they will focus more on mechanism rather than side effect. So please do the mechanism properly. Coming to entacapone and tolcapone, prevent peripheral L-dopa, ये जो है, by inhibiting COMT, used in conjunction with levodopa. Now here is one important point I wanted to write down. Tolcapone जो है, tolcapone, so tolcapone is hepatotoxic. Okay, tolcapone is hepatotoxic. This is important. तो entacapone and tolcapone में जो safe है, that is entacapone. Coming to prevent dopamine breakdown, we have chelagilin, rasigilin, and tolcapone again. Agents act centrally to inhibit breakdown of dopamine. Whereas ये जो है ना, levodopa, carbidopa, ये सब they will act peripherally. Okay, so let's just see. Chelagilin and rasadilin किसमें यूज होता है? Block conversion of dopamine into dopamine by selectively inhibiting MAO-B, which is more commonly found in brain than in periphery. All right. Tolcapone causes BBB and blocks conversion of dopamine to this in the brain by inhibiting central COMT. So if they ask you about the central receptors को blockage मिल रहा है, then you should think about this drug. Okay, this drug. But they are asking that there is a decrease in peripheral conversion and all those stuff. So think about levodopa, carbidopa, and entacapone. All right. If they are asking you about increasing dopamine release, so amantadine and bromocriptine वाला. Now see one more thing. Amantadine जो है ना, वो इसमें भी यूज होता है. Can anyone tell me amantadine और कहाँ पे यूज होता है? Anyone? It is. I give you a hint. It is used as an antimicrobial. याद आ रहा है किसी को? It is used in the treatment of influenza also. Okay, so influenza के लिए भी amantadine एक drug है, and here also Parkinson's में भी amantadine is. So both are same. Okay, keep this in mind. Influenza drug that is used in Parkinson treatment also. Okay, so amantadine is important. तो ये सब दिया हुआ है. Just go through this. This is what we have studied about उसका pictorial representation. Carbidopa, levodopa. Again I am telling you carbidopa, levodopa पे काफी सवाल आए हैं. So why give together? तो ये डोपामिन इन ब्रेन, अनलाइक डोपामिन, ये सब आपको याद रखना है. ओके, दिस इज द रीजन. एंड सी, दे विल कंफ्यूज यू. इन स्पाइट ऑफ यू नोइंग एवरीथिंग, दे आर गोइंग टू कंफ्यूज यू. ओके, दे आर गोइंग टू कंफ्यूज यू. तो आपको एकदम क्लियर कट मैकेनिज्म होना चाहिए. यू शुड बी क्लियर कट विद द एप्लीकेशन ऑफ कार्बिडोपा एंड लीवोडोपा. दे विल बी जस्ट प्लेइंग विद द लैंग्वेज ओवर हियर. ओके, meaning will be same. They will be just playing with the language and confusing you. So make sure you know them properly. All right. So coming to the Alzheimer drug, these three drugs you need to remember. They are acetylcholinesterase inhibitors. First 9 adverse effect are nausea, dizzy, counterindicated patient with cardiac conduction abnormality. Okay. यहाँ पे they won't ask this. They will ask you the name of drug and the mechanism. Alzheimer's का दिया रहेगा. What will you give for a treatment? Okay. Another drug is memantine. Remember the mechanism, and used for moderate to advanced dementia and everything like that. Coming to ALS. ALS we discussed in the spinal cord disorders. We have the drug riluzole. यही mechanism याद रखो. It engages in survival. Huntington disease we have tetrabenazine. Mechanism याद रखो. Used for, and yeah, Huntington में this is asked in NBME, and it was asked to me in the exam also. Okay, they asked me the mechanism. So make sure you know the mechanism very well. Okay, see, pharma mein there is nothing high yield. You just have to remember the mechanisms and stuff. Okay, now coming to anesthetics. Now anesthetics is important because they like to play with the MAC and the potency. Okay, तो जिसकी MAC बड़ी होगी उसकी potency कम होगी. They have given here potency is 1 by MAC. So if potential is increasing, MAC is going to decrease. Okay, so now another thing that they want to ask here is drugs with decrease in solubility in blood, rapid induction and recovery time, increase in solubility in lipids, increase in potency. Now one more thing I have written over here. UWorld में जितने भी क्वेश्चंस है रट डालो. They won't ask anything out of UWorld. Okay, similar was in anatomy. They won't ask anything out of UWorld. Okay, yeah. So three systems where you need to focus more on UWorld is anatomy, ophthalmology, and this anesthesia. Okay, क्योंकि UWorld में there are so many questions, and based on that only the questions will be asked in the exam. Okay, so सबसे पहले देख लेते हैं this one. Inhaled anesthetic, remember the name. Effects, you should remember myocardial depression, respiratory depression, and yeah, cerebral metabolic demand decrease करती है. Adverse effect में halothane causes hepatotoxicity. This is asked in UWorld so many times. Nephrotoxicity by methoxyfluorine. Okay, and yeah, malignant hyperthermia. Now here what you will do is, see, inhale anesthetic or succinylcholine induce severe muscle contraction and hyperthermia. This is very important. Severe muscle contraction and hyperthermia. So now what you will do is, how it is occurring is, so mutations in ryanodine receptor causes increase in calcium release from sarcoplasmic reticulum. And guys, this question is 100% going to come in exam. 100%. 3 से 4 NBME में ये सवाल है. UWorld ने भी बहुत सारे सवाल दिए हैं, and 100% this is going to come in exam. They will give you malignant hyperthermia. They will give you that after taking succinylcholine this is occurring, and they will ask you what is the mechanism for that. So they will give you this mutations in ryanodine receptor that causes increase in calcium release. Okay, this is, I'll mark it very very high yield. For sure it is going to come to exam. Okay, so yeah, and another thing they ask about the treatment also over here. So dantrolene ryanodine receptor antagonist. So this is very important. Malignant hyperthermia is very important. इसको याद करके जाना, भूलना मत. Coming to intravenous anesthetic, just remember the mechanism. That's it. Remember the mechanism और कुछ मत करो. इसमें और कुछ नहीं आएगा. They will like give you the case, then they will say this anesthesia was infused, and either they will give you the name or they will give you the mechanism. You have to identify which anesthetic was given. Okay, that's it. Local anesthetic, you have to remember the mechanism. Block neurotransmission via binding to voltage gated calcium channels on inner portion of channel. Okay, this is important. Can be given with vasoconstrictor, usually epinephrine to enhance block duration by. This is very important. This was given in UL. Okay, and I think in NBME also this was given. So this becomes important. Local anesthetic को epinephrine के साथ क्यों देते हैं? This is the question. Okay, and yeah, order of loss. First, there will be loss of pain, temperature, touch, and pressure. All right. So that's it. That's it. And yeah, this bupivacaine can cause cardiovascular toxicity. That's it. So this is all important for local anesthetic. Coming to neuromuscular blocking drug, depolarizing and non-depolarizing. What is important over here is sacchinylcholine. Sacchinylcholine, remember the mechanism. And as we saw before, sacchinylcholine can cause malignant hyperthermia. All right. Another complication, hypercalcemia, hyperkalemia, which we already studied. Okay. Increase in prolonged muscle paralysis in patients with pseudocholinesterase deficiency. This is also very important. They have asked this along with malignant hyperthermia. Okay, so make sure आप एक एक लाइन malignant hyperthermia के related ना भूले. Sacchinylcholine, dantrolene. Then you have to remember that ryanodine receptor वाला. Then you have to remember then like increasing risk of prolonged muscle paralysis in patients with pseudocholinesterase deficiency. Pseudocholinesterase deficiency is important. Okay, so ये part आपका बहुत बहुत high dose आता है. So make sure you don't forget it. All right. Coming to non-depolarizing neuromuscular blocking drug. Remember this drug. Okay, and remember the mechanism. So reversal, how you will be doing? They haven't asked. So just remember neostigmine. Okay, just इतना याद रखो. They won't ask more questions regarding this, but this becomes very important because sacchinylcholine is causing malignant hyperthermia. All right. Skeletal muscle relaxation. Just remember the mechanism and drug. मैकेनिज्म एंड ड्रग याद करो, कुछ नहीं. डेंट्रोलिन का तो मैंने आपको बता ही दिया. मैलिग्नेंट हाइपरथर्मिया में यूज होता है. इट इज एन एंटागोनिस्ट ऑफ राइनोडिन रिसेप्टर. ऑलराइट. ओपियोइड. Opioid. I wrote before also. Definitely one question is going to come. Sketchy has explained it so beautifully. You won't forget anything. Okay. तो फिर भी देख लेते हैं. Now see. First let's come on the adverse effect. ठीक है. पहले adverse effect पे आके बाकी सब तो आपको पता है. So adverse effect is what they ask focus on more. Okay. So nausea, vomiting, pruritus. Okay. And along with that, one important factor that they will give you is yawning. Okay. This yawning is very important. So nausea, ये सब vomit, yawning is very important. Okay. So ये सब आपको याद रखने. Respiratory depression, constipation, sphincter of Oddi spasm, meiosis. So ये सब आपको याद रखनी. Treat toxicity with naloxone and prevent relapse with naltrexone once detoxified. I think we discussed this in psychiatry. Naloxone, naltrexone, buprenorphine, ये सब हमने discuss किया हुआ है. All right. So make sure you know this. And yeah, they will give you nausea, vomiting, pruritus, yawning. Yawning mostly वो लोग withdrawal के साथ देंगे. ओके. सी yawning ऐसा सिम्टम है जिसमें हमने कहीं पढ़ा ही नहीं है. वी हैवंट सीन yawning anywhere. So if in the question you are been asked about yawning, think कि यहाँ पे opioid का कुछ तो problem है. Alright. So let's just see what is the mechanism. Act as agonist as opioid receptors to modulate the synaptic transmission. So this is what, yeah, this line is very important. Close presynaptic calcium channels and open postsynaptic potassium channel. This is very important. They have asked so many times. Okay. And what does it do? It inhibits release of all the neurotransmitters. Now coming to, they will ask you what are partial agonists and what are full agonists. Remember the name. Okay. Remember the name. Partial agonist is only buprenorphine. Easy to remember. Antagonists are naloxone, naltrexone, methyl naltrexone, everything. Okay. So just try to remember the name. Try to remember the adverse effect. That's it. Nothing else you need to know. All right. Coming to tramadol, Very weak opioid agonists also inhibit the reuptake of norepinephrine and serotonin. Remember the two neurotransmitters, norepinephrine and serotonin. Okay, adverse effects are similar. Okay, moving ahead. They haven't asked, so you can just give it a read. Okay, they haven't asked about this. All right. Moving to capsaicin, they have asked this. I think they have asked this in NBME as well as in UL. UL में one question in NBME two questions I get. Okay, so excessive stimulation and desensitization of nociceptive factors decrease in substance P release. This is what they have asked. Capsaicin ka what is the mechanism to decrease in substance P release? This is what they have asked. Okay, so make sure you know them. It is also used for neuropathic pain. All right. Now, when I discuss ophthalmology, when I discuss glaucoma, I told you they won't be asking you about the glaucoma mechanism and everything. But what they ask is glaucoma therapy. Okay. Here, what you need to do, these are the classes of drugs. These are the name of drugs. Name of drugs are easy to remember. Remember. Now, yes, you have to remember which class will decrease aqueous humor synthesis and which class will decrease outflow of aqueous humor. Okay, so you need to do this. This the aqueous humor synthesis decrease, aqueous humor synthesis decrease. So these three drugs are going to decrease, and these two drugs are going to increase the aqueous humor outflow. Okay, so this is one important point that you need to remember here. Second, you need to see what is the change in the pupil after giving this drug. Okay, so beta blocker में no change, अल्फा एगोनिस्ट में माइड्राइसिस, डायूरेटिक्स में नो चेंज, प्रोस्टाग्लैंडिन में दे विल चेंज द कलर ऑफ आइरिस एंड कोलिमोमिमेटिक्स में मायोसिस. दिस इज वेरी इंपॉर्टेंट. युवल ने तीन चार सवाल पूछे. दे हैव सेड कि ग्लाइकोमा इज अकरिंग and one of the drugs was given, one that caused mydriasis or that caused meiosis or no change in the pupil was seen, and you have to remember the mechanism. So this is very important. Remember the mechanism, remember the names, and remember the pupillary effect. Okay, that's it. That's all you need to remember for the glaucoma drug. And I think with this we have finished the CNS pharma. Once again, I am repeating, CNS pharma में दिक्कत आ रही है. Then think about revising it once from sketchy pharma, because they have explained it so beautifully and they have given the sketch. You don't have to remember any information. Just remember the sketch and you are good to go. All right. So benzodiazepine and barbiturates, I recommend you to watch it. Opioid, I recommend you to watch it. And if you want to even improve your scores in this, what do we say? Uh, Anti-epileptics, you can go and watch it. Okay, but that can be avoided because I have already simplified it for you. So CNS pharma, very high yield, ध्यान से करना. And with this we finished neurology. And one more thing, neurology पे ज़्यादा time दो. At least 4 questions, 3 to 4 questions in one block will be asked from neurology. Okay, very simple system. Just remember the information, apply the logic, good to go. All right. So let's just start with CVS. Now coming to CVS, CVS is not that high yield. Okay, it is high yield, but not that. Like you can expect 2 questions per each block. It is a big system. That's why it becomes high yield in the terms of quantity of questions. So per block, you can expect 2 questions. Okay, but neuro is 3 to 4 questions. All right. So CNS is a big system. We have to do lots and lots of stuff over there. So let's just start with CNS. In CNS, you have CVS, you have to focus on the physiology part also and little bit of anatomy part also, and then I think we'll be good to go. All right, let's start from the embryology. I'll try to finish the entire CVS today. Let's see. Tomorrow we'll be doing the reproductive part. I think it will take 2 days, one day only. I'll try to finish. So let's start. In embryo, don't have to do anything. Okay, just understand the separation of chambers. Okay, just understand this and remember patent foramen oval. Just remember the patent foramen oval. But before that, just give a read. Just give a read. You don't have to remember anything. Don't waste your time in going into detail over here. बस एक बार read कर लेना so that you just have the concept at the back of your mind. Okay? NBA में इतना नहीं पूछा है. Yuval has asked one or two questions, but not important. This patent foramen oval is important. So caused by the failure of septum primum and septum secundum to fuse after birth, most are left untreated can lead to paradoxical emboli. This is what is important. Paradoxical emboli. So venous thromboemboli entering the systemic arterial circulation to right to left shin as occur in ASD. So what two things are important over here is failure of fusion of septum primum and septum secundum, and paradoxical emboli is important. These two things are important in patent foramen oval. Rest all just give a read and understand. Okay. Same in the ventricles also. Just give a read. Just give a read. No problem. Outflow tract formation. Now, outflow tract formation, what are they? They are basically a neural cell migration. That's it. Nothing else you have to remember. Okay. Valve development, aortic pulmonary derived from endocardial cushions of outflow tract. Mitral and cuspid derived from fused endocardial cushions of AV canal. So this is important because they have asked what is the embryologic basis for aortic valve or mitral and tricuspid valve. So this becomes important. Okay. Now, yeah, this aortic arch derivative they used to give in CNS first. But here, in the latest edition, they have asked in CVS. So it becomes a topic of CVS. Let's just discuss it. First, yeah, see, let me see if they have asked pharyngeal arch derivative also. Okay, they haven't asked. This aortic arch derivative, take a printout and stick it on the front, stick it on the table or the wall where you like are studying. Okay, and I think the latest edition didn't give the pharyngeal arch derivative. I didn't see. But अगर दिया है and if I forgot, so let me know. I think in the reproductive part में शायद दिया हो. So the pharyngeal arch derivative, aortic arch derivative, these are very important. Direct questions will be asked, and it is difficult to remember because you have to remember them in line. Only then you will be able to remember it. Okay, so let's just see. First arch, maxillary artery. Second arch, stapedial and hyoid artery. Third arch, common carotid artery and proximal part of ICA. Fourth arch, aortic arch, right, proximal part of right subclavian vein, sixth artery, sorry, and proximal part of pulmonary artery and ductus arteriosus. Okay, now the sixth one they you love to ask so many times because they will be asking you about PDA. So what they will do is after giving the diagnosis of PDA, they will ask you where the problem has occurred in the embryology. So answer will be development of sixth aortic arch. Okay, so this is how you have to remember. You have to remember the artery in each of the following arch. Very important. Okay, direct questions will be asked here. They won't torture you over here. Direct question. Okay, next, heart embryology. Just give it a read. Okay, just give it a read, or you can try to remember it also because in UL 1 to 2 questions have been asked. एनबीएमए में आई डोंट थिंक डायरेक्ट क्वेश्चन हैज बीन आस्क्ड बेस्ड ऑन दिस. जस्ट ट्राई टू रिमेंबर कि कौन सा पार्ट कौन किस में डेवलप होता है. ओके, एंड दिस इज द बेसिक, यू मस्ट बी नोइंग दिस ऑलरेडी. लेट्स मूव अहेड. फीटल सर्कुलेशन. नाउ फीटल सर्कुलेशन में क्या इंपॉर्टेंट है, दिस, ये सब तो आप कर लोगे. यू मस्ट बी नोइंग द पाथवे ऑफ फीटल सर्कुलेशन. ओके, पाथवे यू शुड नो. ओके, पाथवे आनी चाहिए. What will be bypassing? You will be bypassing liver, you'll be bypassing lungs and everything like that. Okay, so what important point I want you to remember here is okay, yeah, what important point I want you to remember over here is at birth infant takes a breath, decrease in resistance in pulmonary vasculature, increase in left atrial pressure versus right atrial pressure. Okay, foramen oval closes, increase in O2 and decrease in prostaglandin, closure of ductus arteriosus. Each and every point is very important over here. Each and every point. Okay, ये आपको आएंगे एरो वाले में. They will ask you arrow resistance increasing where lung, pulmonary circulation, atria, left atria, right atria. They will ask anything. Okay, so you should be knowing this. Okay. Now another thing, NSAID example indomethacin or ibuprofen or it can help close the PDA ligamentum arteriosus. ओके तो ये दो पार्ट आपको अच्छे से आने चाहिए. बाकी फीटल सर्कुलेशन का पाथवे दैट इज तो इंपॉर्टेंट. दैट इज व्हाट अबाउट द फीटल सर्कुलेशन. ओके एंड या दिस just give it a read. Don't remember this, they have never asked, just give it a read. Alright, so see MBO is not that high yield in CVS like NR, physio, patho. Embryo में they will just give you direct answers, direct question. Okay, but ये part था थोड़ा tricky because here you have to remember the arrows. बाकी rest all embryo is just फटाफट देखो और आगे बढ़ो. Don't have to give so much time in embryo over here. Remember this. Remember the aortic arch derivative. That is very very important. Aortic arch derivative और valves का embryological structure क्या था? Mitral and tricuspid and aortic और pulmonary and the last one is patent foramen oval में क्या होता है? Okay. So these are the things you need to remember in embryology. Let's move to the anatomy part now. Now here we have to remember few things over here that LA is the most posterior part of heart. This is one important point. Okay. Now what how they are going to ask here is see in the UL you must have seen कि enlargement of LA can lead to compression of esophagus and or left recurrent laryngeal nerve. So this is what is causing Ortner syndrome. Okay. Now see how they are going to cause. They will give you TTE exam. TTE exam means trans tracheophageal. Sorry, there is a full form of transesophageal transthoracic esophagography, something like that. Okay, so in the UL they have said that we have done TTE and we found that the esophagus was constricted. Okay, esophagus constricted. What part of heart or which chamber of heart is responsible for causing this problem? So your answer will be left atrium. Left atrium से esophagus compressed होता है. And they might ask you the syndrome name also. अगर esophagus compressed हो गया, so what is the condition? Ortner syndrome. Okay. Now coming over here, right ventricle is the most anterior part of the heart and most commonly injured in trauma. Left ventricle is two-thirds and right ventricle is one-third of the inferior cardiac surface. Now see what happens is in the see they might give you the X-ray like CT like this or the X-ray like this. What they will do is you have to remember this. Okay, ये locations आपको याद करने हैं. Okay, sometimes what they do is they will say the pacemaker was installed in the heart or in the thorax of a patient. Now they can say the pacemaker was either installed over here, 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 or here. You have to say you have to identify the location. This is how the questions will be asked. Okay, आपको location पता होनी चाहिए कि कहाँ पे क्या है. Alright, so left ventricle का, right ventricle का, atrium, right सब याद होना चाहिए आपको. Everything you should remember. Okay, so make sure you know this properly. Sometimes in the UL what they give is instead of this I'm rubbing this. Okay, but make sure you know this. In the UL what they will give is they will give this much big heart. Okay, this much इतना बड़ा heart दे देंगे and then they will ask uh, what is this structure, what is this part. So your answer is going to be right ventricle. Okay, right ventricle is the anterior most. Okay, so UL has many questions related to this. Please follow up in UL regarding the anatomy as I already told you. So that is going to happen. Okay. Pericardium, fibrous parietal epicardium. Pericardial space lies between this and yeah, one important point over here, one important question over here. Pericardial effusion होता है ना? Pericardial effusion. So the fluid that is collected, it is in the pericardial space. So in the exam, they won't ask pericardial space. They will ask you between parietal and visceral pericardium. Okay. Actually, I'm sorry, ये थोड़ा गलत हो गया मुझसे. They will ask you the region over here between parietal and viscerous pericardium. I think epicardium only. Yeah, I'm sorry, I was right. Okay, so pericardial space, parietal and epicardium. तो ये आपको याद रखना है. वन क्वेश्चन वाज देयर इन एनबीएमई. ओके, दे आस्क्ड द पेरिकार्डियल डिफ्यूजन का डायग्नोसिस था, एंड देन दे आस्क्ड वेयर इज द फ्लूइड accumulated. So pericardial space नहीं होगा, so region between parietal and visceral pericardium. Okay, instead of epicardium they will give you visceral epicardium pericardium. Okay, so make sure you know this. Coming to the coronary blood supply, left anterior descending, posterior descending artery, RCA. Now see, one simple thing I am telling you, if the question is asking you about RCA, okay, right coronary artery, so they will be talking you about the inferior portion of the heart. Inferior portion of heart. Another thing about RCA, they supplied AV node and SA node. ओके, दिस इज वेरी इंपॉर्टेंट. यू वर्ल्ड में काफी सवाल है रिगार्डिंग द आर्टियल सप्लाई ऑफ हार्ट. ओके, so before coming over here, before actually mugging things over here, go back to your university anatomy notes and do it properly, because so many questions have been asked in UL and in NBME also they have asked. Okay, so make sure you know the arterial supply of heart properly. Coming to PDA, posterior descending artery, supplies posterior one-third of interventricular septum, posterior two-third of ventricles. LED, anterior two-third of interventricular septum, anterolateral papillary muscle, anterior surface of LV. Okay, so now dominance. In the U world, they have talked about dominance also. Okay, so right dominant circulation, PDA arises from RCA. Left dominant के लिए PDA arises from left circumflex artery. Co-dominant circulation, PDA arises from both LCX and RCA. Okay, so you need to remember over here. And they have also asked about the venous supply, but only two things are there in venous supply. Write it down. Great cardiac vein accompanies anterior interventricular artery. That is the LAD, branch of LAD only. Okay, and another small cardiac vein accompanies coronary sulcus. Okay, and middle cardiac vein PIV, posterior interventricular artery. So guys, this is the language of UWorld. Okay, ये UWorld से extra points मैंने लिखे हुए. And one or two questions were there regarding the venous supply also. So I want you to remember this also. Okay, arterial supply and venous supply of heart, जितना अच्छे से करोगे उतना अच्छा है, because if we go ahead while we are studying the myocardial infarction, in that you will be requiring a lot of knowledge regarding the anatomy. Okay, so make sure you know this properly. Arterial supply very important, and heart के anatomy, posterior one will be left atrium and anterior is right ventricle. So these small things you have to remember. Moving ahead, so that's it for anatomy. Anatomy में इतना ही था और कुछ भी नहीं करना है हमें. And the 2 points, write down more 2 points, you can write it down for the anatomy. Anterolateral papillary muscle, it is having dual supply, LAD, LCX. Okay, another point, posterior medial papillary muscles, and the answer will be RCA, right coronary artery. Because see, one general rule in MBBS, okay, एक मैंने देखी है, मैंने notice की है, one general rule in MBBS, what is that? Whenever you are talking about the things in the right, they are always going to either be in the posterior or medial. Okay, ये general rule आप डाल दो दिमाग में. I'm writing over here. Whenever you are talking about right side, it will always be related to medial and posterior, and left always going to be anterior and lateral. ठीक है? This is why I am saying you, because एग्जाम में कुछ भी नहीं आया, ओके कुछ भी नहीं आया, तो एटलीस्ट थिंक कि हाँ राइट वाला है तो मोस्टली पोस्टीरियर और मीडियल ही होगा. Okay, this is going to help you a lot. I have noticed this. This is like ये कहीं पे लिखा हुआ नहीं है. This hasn't been written anywhere, but you can apply this because 99% of the questions I have seen this. If they are saying about right, it will be three things: medial, posterior, and inferior. Inferior लिखना भूल गया, inferior भी लिख दो. Inferior, inferior, medial, and posterior. And if they are talking about left, superior, lateral, anterior. ओके ये याद रखना, बहुत काम आएगा इन द क्वेश्चंस वेयर यू आर नॉट एबल टू थिंक एनीथिंग, यू आर नॉट एबल टू रिमेंबर एनीथिंग. ये रूल अप्लाई कर दो, यू आर गुड टू गो. ऑलराइट, so that's all about the anatomy, that's all about the embryology. Now focus on the most important part, that is the physiology. Okay, cardio में physiology बहुत important है, and so many questions are there regarding the physiology only. Okay, all right, so these are the parameters, and I hope you all have studied BNB properly. Okay, I hope you have done BNB properly or any other resources. What I want you to know is you should be knowing a proper concept about preload, afterload, ejection fraction, venous return, stroke volume, contractility, then about heart rate. Okay, ये सारे parameters की information एकदम clear होनी चाहिए. So many questions will be asked. So many, mark my word, and they will play with you. This is the part that will be playing with you. Cardio is the most difficult system in the exam, and it is a high yield, but it is not like not so many questions have been asked. Max to max two questions per block, and sometimes one block will be having just one question. Okay, and in that question, physiology will be very nasty. Okay, and this is the most difficult system. I am telling you, so you have to do it. So चलो करते हैं. Stroke volume affected by contractility after load and preload. Okay, so इसमें आपको पता होना चाहिए कि preload से increase हो रहा है या preload से decrease हो रहा है stroke volume everything. So this is where you will come here. Okay, so preload increase हो रहा है तो stroke volume increase होगी. आप preload decrease हो रहा है stroke volume decrease. Afterload and stroke volume का opposite है. So this is what you have to remember here. This is what you have to remember about the parameter. Okay. And what else you have to remember here is, okay, in stroke volume only this much. Coming to contractility. Contractility and stroke volume increases with catecholamine stimulation, intracellular calcium, decrease in extracellular sodium, and digoxin. So this is all the factors you have to remember. And decrease का उसका उल्टा हो जाएगा. Okay. So what else you need to remember? Contractility का मतलब क्या है? In simple term, how hard the heart squeezes. Okay, कितने जोर कितने दम से हार्ट पंप कर रहा है, that is what known as contractility. Just remember these factors, you are good to go in the exam. Okay, coming to preload. तो preload में क्या करना है, यहाँ पे कुछ चीजें हैं, I will write it down for you. To increase preload, what you need to do, either add volume, decrease in heart rate, constrict veins. Okay, and to increase afterload, what you need to do, raise MAP, obstruct outflow of left ventricle. It can be anything like aortic stenosis or hypertrophic cardiomyopathy, anything. Okay, so afterload को increase करना है तो आपको blood flow को रोकना है, preload को increase करना है तो blood बढ़ना है. This is the simple rule. ओके, एंड कीप दिस इन माइंड, दिस इज वेरी इंपॉर्टेंट. सो लेट्स जस्ट सी कि पीरियड और उसमें क्या दिया हुआ है. डिपेंड्स ऑन वेनस टोन एंड सर्कुलेटिंग ब्लड वॉल्यूम, वेसोडाइलेटर डिक्रीजेस प्रीलोड. क्योंकि वेसोडाइलेट डायलेट करेगा. ओके, तो वेसोडाइलेटर आर गोइंग टू डायलेट इट, सो ब्लड फ्लो कम होगी. ब्लड फ्लो कम होगी, ब्लड वॉल्यूम कम होगी. ओके, सो सी, एड वॉल्यूम और कॉन्स्ट्रिक्ट वेन. कॉन्स्ट्रिक्ट करोगे, फ्लो बढ़ेगा, प्रीलोड बढ़ेगा. ओके, you have to think generally, and this is where the CVS is going to be the more difficult part. Okay, so इसको सोचना है थर्ड डायमेंशन में जाके, and then only you will be able to mark it correct. One more thing, in the last week before you are appearing for the exam, कार्डियोवैस्कुलर फिजियोलॉजी एंड पैथोफिजियोलॉजी को अच्छे से यूएल से रट के जाना. रट के जाना इट मीन्स वन वन क्वेश्चन शुड बी इन योर माइंड. हाँ, ऐसे क्वेश्चन आया था, व्हाट शुड बी द आंसर. ऐसे क्वेश्चन आया था, व्हाट शुड बी द आंसर. ओके, तो यूवर्ल्ड में पैथोफिजियो एंड फिजियोलॉजी ऑफ सीबीएस वेरी इंपॉर्टेंट. पैथोलॉजी इज डैम इजी. ठीक है, पैथोलॉजी तो बहुत इजी आएगी, बट मेन इज पैथोफिजियो एंड फिजियो. ओके, सो आई टोल्ड यू प्रीलोड का ये बेसिक्स है, आफ्टर लोड का ये बेसिक्स है. ओके, सो वी कैन से कि इंक्रीज इन प्रीलोड ऑल्सो इंक्रीज इन कार्डियक आउटपुट. ब्लड ज्यादा जाएगा, ज्यादा कार्डियक आउटपुट निकलेगी. ओके, सिंपल सा फंडा. ऑलराइट, कमिंग टू आफ्टर लोड अप्रोक्सीमेटेड बाय एमएपी, छोड़ दो ये. एलवी कंपेंसेट फॉर इंक्रीज इन आफ्टर लोड बाय थिकनिंग हाइपरट्रॉफी. ओके, आर्टीरियल वेसोडाइलेटर डिक्रीज आफ्टर लोड, क्योंकि कंस्ट्रिक्ट करेंगे तभी तो ऑब्स्ट्रक्शन होगी, ऑब्स्ट्रक्शन होगी तभी तो आफ्टर लोड बढ़ेगा ना. ऑब्स्ट्रक्शन हो गई तभी तो खून बाहर, ब्लड बाहर नहीं निकलेगा. Obstruction, if there is obstruction only, then the blood won't be going back out. That is what afterload, the pressure required to pump the blood outside. All right, that is what afterload. So in order to increase afterload, we have to constrict, we have to increase the pressure. If we dilate it, the pressure ही नहीं आएगा ना. Simple. Think like this, you will enjoy. Think like this. Okay, so ACE inhibitors and ARBs both decrease preload and afterload. Important line. Chronic hypertension में MAP increase है, LV hypertrophy हो जाएगी. So these are the few points that you have to keep in mind while thinking about preload and afterload. Now, one graph is there. Preload directly proportional to blood ejection. Okay, preload is directly proportional to blood ejection. All right, and that's it. Nothing. Okay. Another thing, preload को measure करना हो तो always look at end diastolic volume. Okay, preload को measure करना हो, if you want to look at the preload, always look at end diastolic volume. All right, so now coming to the myocardial oxygen demand, increasing contractility, increasing afterload, increasing heart rate. Just remember this stuff, nothing else. Okay, तो ये पेज में आपकी काफी सारी चीजें हाईलाइट हो गई, काफी सारे सवाल आए हैं. ओके, स्ट्रोक वॉल्यूम प्रीलोड आफ्टरलोड के हिसाब से, कॉन्ट्रैक्टिलिटी, ये सारे फैक्टर्स के हिसाब से, प्रीलोड के फैक्टर्स कौन से इंक्रीज करेंगे, आफ्टरलोड के फैक्टर्स कौन से इंक्रीज करेंगे. आई हैव मेड यू राइट देम डाउन, and this is the equation. Preload is directly proportional to blood ejection. More the volume of blood, more the preload. More the obstruction, more the pressure that the heart has to apply in order to pump the blood out. That is what afterload is. Okay, so that's all from this page. Moving ahead. Okay, I'll ask you one question over here. If I increase afterload, what will be the effect on TPR? TPR is total peripheral resistance. मुझे बताओ, आफ्टरलोड इंक्रीज किया तो टीपीआर पे क्या वैल्यू आएगा? शेरिन, सुस्ती, एनीवन? You guys are there, right? Give me a thumbs up if you don't want to speak. हाँ, तो शेरिन बताओ, आफ्टरलोड को इंक्रीज किया मैंने, तो पेरिफेरल रेजिस्टेंस है तो उसका क्या असर होगा? इंक्रीज होगा, डिक्रीज होगा? जी, एवरीथिंग इज रिटन ओवर हियर. आफ्टरलोड किससे इंक्रीज होता है ये देखो, फिर मुझे बताओ रेजिस्टेंस इंक्रीज होगी या डिक्रीज होगी? If क्या होगा?
Increase.
It will increase ना, because in to increase afterload we have to give obstruction. Obstruction देंगे तभी तो हार्ट को ज्यादा ताकत लगेगी पंप निकालने के लिए. So there resistance is occurring in the heart to pump the blood. Okay, are you able to link it, Sherin? Are you able to link it?
Yeah.
Okay, so this is how अगर afterload increase हुई तो total peripheral resistance भी increase हो जाएगी. All right, so this is one question they always are love to ask and confuse you with. Okay, another thing, yeah, tell me this. अगर preload increase किया तो venous return पे क्या होगा? Anyone quickly tell me.
बढ़ेगा.
Perfect. क्यों बढ़ेगा? बिकॉज पीलोड इंक्रीज किया, कार्डियक आउटपुट इंक्रीज किया, कार्डियक आउटपुट इंक्रीज किया, वेनस रिटर्न बढ़ेगा. ऑलराइट, so think about everything like this, small things, and your answers will be correct. Okay, so let's just say, moving ahead, cardiac output volume, stroke volume, formula याद रखो, ejection fraction. Okay, just a minute. Yeah, another important point I want you to write it down over here. Systolic blood pressure is determined by stroke volume. Diastolic blood pressure determined by total peripheral resistance. Okay, that's it. Remember this. Moving ahead, ejection fraction formula याद रखो. Cardiac output formula याद रखो. And here important, in early stages of exercise, CO is maintained by increase in heart rate and increase in stroke volume. In later stages, CO is maintained by increase in heart rate only. Okay, this is important. Early stages and late stages. Coming to pulse pressure, remember the formula. Directly proportional to stroke volume and inversely proportional to arterial compliance. Okay, pulse pressure is directly proportional to stroke volume. All right, so यहाँ पे कुछ लिख दो. Compliance inversely proportional to total peripheral resistance. Another thing, if decrease in compliance, increase in pulse pressure, stiff vessel, and if increase in compliance, decrease in pulse pressure, stretchy vessel. All right, so this is what you need to remember. Compliance decrease किया, pulse pressure बढ़ेगा. Compliance increase किया, pulse pressure घटेगा. So this is what they have talked over here. And one thing I want you to remember here is, in U world they have asked about the example. Pulse pressure किसमें increase हो रहा है? So hyperthyroidism, AR, aortic stiffening, OSA, anemia, exercise, सब में. Okay, so decrease in pulse pressure in aortic stenosis. So these examples you have to remember. Okay, examples आपको याद करने हैं. And this is the concept. Along with this, the formula you have to remember. In cardiac output, remember about the maintenance in the exercise. Okay, so that's it. ये आपको याद रखना है. Alright, तो चलो स्टार्लिंग कर्व देख लेते हैं. ये नॉर्मल है, तो अगर उसके नीचे आया तो देयर इज गोइंग टू बी हार्ट फेलियर, एंड ऊपर गया तो इट अकर्स नॉर्मल इन एक्सरसाइज. ओके, तो अगर increase in contractility with corticolamine, ये सब हमने आगे देखा. Decrease in contractility with all those stuff, all of this we saw earlier. Okay, so that's all in this page. Make sure you know each and everything. और क्या याद करना है आपको? Okay, that's it. Moving ahead. Now here you can avoid this. Parallel or series का avoid कर दो. What important one you have to remember here is, arterioles account for most of the TPR. Veins provide most of the blood storage capacity. Okay, viscosity depends mostly on hematocrit. विस्कोसिटी इंक्रीजेस इन हाइपर प्रोटीनेमिक स्टेट एंड डिक्रीजेस इन अनीमिया. तो ये तो इंपॉर्टेंट है. इसके साथ साथ एड एक्स्ट्रा पॉइंट दैट आई एम सेइंग. आर्टरीज एंड वेन्स resistance. Arteries have high resistance, veins have low resistance. Now another thing, capillaries have highest area and lowest velocity. Okay, capillaries have highest area and lowest velocity. Now that's it. Okay, इधर इतना ही याद करना है. You can ignore the series and parallel wala stuff. They have never asked, but yeah, remember this. Capillaries have highest total cross-sectional area and lowest flow velocity, and this is what it will be. Okay, so make sure you know them. ठीक है. And yeah, guys, this is very high yield. Very high yield. बहुत हाई yield है. बहुत सिंपल है. Just remember the graph. Just remember the graph. Okay. अगर ऐसा वाला ग्राफ आ रहा है, आपको बस पैरामीटर्स याद रखना है. पैरामीटर्स याद रखना है. कार्डियक फंक्शन कब ऊपर जा रहा है तो इंक्रीज एनर्ट्रॉपी, डिक्रीज एनर्ट्रॉपी, एंड वास्कुलर फंक्शन कब अलोंग विद दैट. ओके, सो सी गाइस, ये याद करना है. बट व्हाट इंपॉर्टेंट टू रिमेंबर हियर इज अलोंग विद द ग्राफ यू हैव टू रिमेंबर द एग्जांपल्स. इससे सिंपल कहीं भी नहीं दिया है. ओके, जस्ट रिमेंबर द एग्जांपल्स. किसमें पॉजिटिव एनर्ट्रॉपी हो रही है, किसमें नेगेटिव, किसमें पॉजिटिव वेनस रिटर्न हो रहा है, किसमें नेगेटिव, किसमें पॉजिटिव टीपीआर हो रहा है, किसमें नेगेटिव. गाइस, दिस इज वेरी इंपॉर्टेंट. एक क्वेश्चन डेफिनेटली आएगा. ओके, एंड दिस इज वेरी इजी. Okay, if you look at this, if you remember the example, this is going to be very easy. Just remember the graph and this. Okay, and yeah, लोकेशन भी याद रखना. यहाँ के ऊपर जा रही है तो पॉजिटिव है, यहाँ पे नेगेटिव है. ऊपर जाए तो पॉजिटिव, यहाँ पे नेगेटिव. बट यहाँ पे नीचे जाओगे तो पॉजिटिव है. इफ यू गोइंग बिलो इन दिस ग्राफ, only then it is positive. Going up is negative. All right, so make sure you know them. Few important point that I want you to write down is uh, yeah, in venous return पॉजिटिव में आप एवी फिस्टुला भी डाल दो. एवी फिस्टुला. ऑलराइट, एंड अनदर वन, या वेसोप्रेशर के साथ साथ यहाँ पे आर्टीरियो वेनो डायलेटर्स भी डाल दो. ओके, दैट्स इट. डोंट वरी गाइस, दिस इज गोइंग टू बी वेरी इजी. ये पार्ट तो बहुत ही इजी होगा. जस्ट रिमेंबर दिस कर्व्स एंड रिमेंबर द एग्जांपल्स. वेरी इजी. ऑलराइट, so that's all you need to remember here. Coming to the most important part, very high yield. Okay, now here in the UL, how they have asked this, they have asked A, B, C and D, and at each and every location they have asked यहाँ पे क्या हो रहा है, यहाँ पे क्या हो रहा है. So you know, mitral valve closes, aortic valve opens, aortic valve closes, mitral valve opens. So this is very important. Or side by side you have to remember this phase also. This is isovolumic relaxation, contraction, contraction, relaxation. ये सब याद रखना है. Okay, UL में you must have been familiar with all sorts of questions, so you have to remember this. Coming to this diagram, mark my word, very important. Now how to remember this diagram? What you guys do is diagram को देखो and make the same diagram in your notebook without looking at it, because what problem is occurring is mostly they will give you this part. Okay, they will give you this part and then they will ask you यहाँ पे क्या हो रहा है, यहाँ पे क्या हो रहा है, यहाँ पे क्या हो रहा है, and यहाँ पे क्या हो रहा है. Another way of giving the question, they will give you the murmurs AS, AR, MR, MS. ओके, मतलब क्लोजिंग में कुछ प्रॉब्लम आएगी या ओपनिंग में कुछ प्रॉब्लम है. देयर विल बी प्रॉब्लम इन ओपनिंग और क्लोजिंग ऑफ वाल्व, एंड देन दे विल आस्क यू कि कौन सी लोकेशन पे दिस इज अकरिंग. सो यू नो कि यहाँ पे क्लोज हो रहा है माइट्रल वाल्व, यहाँ पे ओपन हो रहा है एओर्टिक वाल्व. ओके, एंड यूवल में यू आर फेमिलियर अलॉन्ग विद दिस एनबीएमई में भी ये सवाल काफी आए हैं. सो यूवर्ल्ड में जितने भी क्वेश्चंस है ध्यान से करो. डू ऑल द क्वेश्चन गिवन इन यूवर्ल्ड विद वेरी like important, give them very important, give proper attention and try to see कि क्वेश्चंस कैसे आ रहे हैं और कैसे मुझे आंसर करना है. ओके. ऑन अदर हैंड, they have, in one of the question they have asked about this also. They gave this diagram and then they asked about the ventricular volume. Okay, so you should know the shape कि जहाँ पे प्रेशर बढ़ रहा है वॉल्यूम कम हो रहा है. ऑल राइट, सिंपल फंडा. अनदर थिंग, JVP के curves, they have asked what each of these curves mean. Okay, so let's just write it down. उससे पहले यहाँ पे देख लेते हैं. जस्ट रिमेंबर द साउंड्स का क्या सीन है, आपको पता ही है सारे मोस्टली, सो आई डोंट नीड टू डिस्कस दिस. अनदर, A wave stands for atrial contraction, absent in atrial fibrillation. Okay. C wave, right ventricular contraction. X descent, Y descent, very important. X descent मतलब देखो and Y descent मतलब देखो. Y descent is seen in constrictive pericarditis and absent in cardiac tamponade. This is very 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 high yield, this line. Okay, X descent and Y descent. Even from the NEET PG point of view, USMLE point of view, FMG point of view, everywhere this is very commonly asked. Okay, so ये सारे waves के आपको मतलब पता होने चाहिए. And what they will do, they will definitely give you this question. A, C, X, Y, V. As a wave, they will make a wave and then they will ask you, what does A signify? What does Y signify? X signify? Everything like they will ask you. Okay, if you have given NBME, you must have come across this. All right, so make sure you know them. And yeah, other extra point that I want you to write down is uh, large A wave. Large A wave is seen in tricuspid stenosis. Okay. Another thing, Canon A wave. Canon A wave is seen in AV dissociation, atrioventricular dissociation. Another one, giant V wave, seen in tricuspid regurgitation. All right, so this is what you need to remember. And एक हिंट दे देता हूँ यहाँ पे जो यूएल के बेसिस पे है. Here there will be aortic regurgitation. Here there will be aortic stenosis. And again over here there is going to be aortic regurgitation. You must have seen UL में ऐसे ग्राफ बना के रख देते हैं and then they discuss about some particular type of valvular disorder and then they ask you to locate the location where the problem is occurring. याद आ रहा है ना, यूएल में ऐसे क्वेश्चंस काफी आए हैं. तो AR AS के लोकेशन मैंने दे दिए, MR MS के you can find it out from the UL. Okay, so this page is of very very high yield, so many questions are there in UL. All right. Another high yield. Each and every page in cardiac is very high yield and very difficult. So more and more question solving is what you are going to get more and more idea. All right. तो आ जाओ इसमें देखते हैं. Yeah, one important hint I will give you is if they are saying whether there is a problem in the afterload, think about aortic stenosis. Preload पूछ रहे हैं, think about these two. Okay, and if they are talking about contractility, think about this. All right, and now see, this is going to be difficult to know. Okay, but this you can remember. Just remember the curve. अगर ऐसा कर्व आ रहा है तो आफ्टर लोड, ऐसा आ रहा है तो प्री लोड, ऐसा भी आया प्री लोड, and if it is like this, it means the problem in the contractility is there. Okay, and another thing that you need to remember here is you have to remember whether end systolic volume is increased or end diastolic volume is increased or stroke volume is increased. Okay, so आप ये ग्राफ देख के तो पता लगा ही सकते हो कि end systolic volume increase हो रहा है, end diastolic volume. It is the same thing that is given over here. Okay, same thing that is given over here. It is just in the fancy term that they like to ask. So remember कि afterload है तो ऐसे आएगा, प्रीलोड है तो पूरा आएगा, एक और प्रीलोड है तो अंदर भी आ सकता है, एंड कॉन्ट्रैक्टिलिटी में पूरा ओवल आएगा। ऑलराइट, सो अलोंग विद दिस जस्ट रिमेंबर ESV इंक्रीज तो स्ट्रोक वॉल्यूम डिक्रीज, यहाँ पे दोनों डिक्रीज, पे दोनों डिक्रीज। ओके, so just remember one thing. Okay, and one important table I will write down for you is contractility increases and decreases. तो इसमें क्या होगा, इसमें if contractility is increasing so ESV will decrease, stroke volume will increase, but if contractility is decreasing ESV will increase, stroke volume will decrease. So remember this. Okay, तो physio is all about game. If you understood the game, जितना अच्छे से समझोगे उतने ज्यादा क्वेश्चन सही होंगे। Alright, so let's just go ahead. Splitting, ignore this. Splitting is a part of step 2 सीखे, step 1 में splitting का कोई फंडा नहीं आएगा, so ignore the splitting. Okay, but these 3 pages, not actually 3, this entire 5 pages, this are going to be a torture for you in the exam. So make sure जो जो information याद करनी है अच्छे से याद करो, because sometimes in the exam you are not going to get time, your brain won't be in that situation to think more. I am telling you from my experience. Okay, it is an 8 hour exam, and after 2 to 3 hours your brain is totally wiped off. So you won't have that capability ki, yeah, I'll think in the exam, I'll apply the concept in the exam. That is not possible. All right, so let's move ahead. We have auscultation of heart, and this is the most interesting part in the exam. You know, in the UL what they say, in the UL they ask you to hear the sound. Okay, they ask you to hear the sound and they give the location APTM. They will give the location कि A पे ऐसा sound आ रहा है, P पे ऐसा sound आ रहा है. Exam में they are not going to tell you. Okay, exam में what will happen is, exam में they will give this. Okay, exam में they will give this. All right, and they will give you a virtual stethoscope. वर्चुअल स्टेथोस्कोप से आपको पता लगाना है, यू हैव टू फाइंड आउट कि कौन से रीजन में मरमर सुनाई दे रहा है। ऑल राइट, सो यू हैव टू टेक द माउस, कीप इट ऑन द ए एरिया, यू हैव टू हियर, सुनाई दे रहा है नहीं, यू हैव टू टेक इट टू बी, पी हियर नहीं, टी हियर नहीं, एम यस मरमर इज एबल टू हियर। देन आफ्टर दैट यू हैव टू डिसाइड, एम पे सुनाई दे रहा है, क्वेश्चन में देखो मरमर सुनो, फिर पता लगाओ कि भाई कौन सा मरमर है। ओके, सो इन एग्जाम यू विल बी हैविंग वर्चुअल स्टेथोस्कोप, द क्वेश्चन वोंट बी टेलिंग यू कौन से लोकेशन में मरमर आया है। ओके, सो जस्ट रिमेंबर कि लोकेशन के साथ, लोकेशन में कौन कौन से मरमर दिखते हैं, बिकॉज इन एग्जाम यू हैव टू फाइंड आउट ऑन योर ओन। अनदर थिंग, कमिंग टू मरमर्स, पहले मरमर्स पे आ जाते हैं, फिर मैं मैन्यूअर्स बताता हूँ। मरमर्स, go to YouTube and listen murmurs every day. Listen every day. ओके, पता लगाओ क्रिस्टेंडो डिक्रिस्टेंडो कैसे हो रहा है, पता लगाओ एमवीपी में टिक टिक डिक डिक के बीच में आपको पकड़ आना चाहिए। ओके, इन एग्जाम यू विल बी गिवन नॉइज कैंसिलिंग हेडफोन, दे आर ऑफ गुड क्वालिटी। ओके, बट you should be able to identify the murmurs. Okay, that's very important. So YouTube पे जाओ, murmur सुनो, जितने ज़्यादा सुनोगे उतना अच्छा रहेगा। All right, and yeah, even you should even hear the heart sound. Heart sounds भी सुनने पड़ेंगे, डिक 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 डिक। Okay, heart sound नहीं समझ आया तो murmur कैसे पकड़ोगे? All right, and sometimes in the question they will say no murmur is heard. That is also a thing. All right, so let's just come to the manure. Just remember at what location which murmur you are seeing. All right, coming to standing Vasalva manure or manure. So this Vasalva manure you have to remember, and along with that you have to remember कि preload किस में increase हो रहा है, afterload किस में increase हो रहा है. Okay, so this is important. Along with that you have to remember the murmurs which are increased with what manure. Okay, so ये पूरा टेबल बहुत ही इंपॉर्टेंट है. So many questions are there in UL, and so many will be there in NBME also. Okay, this is all about the mugging up information, but this is, you have to practice, you have to locate yourself, APTM कहाँ कहाँ आ रहा है, hear the murmurs on YouTube, and good to go. UL के भी murmurs एक बार सुन लेना है. Coming to the murmurs, now these are also very high yield part. Yeah. Coming to aortic stenosis. So aortic stenosis में, let's just see what it is given here. Okay, then I'll add the extra point. Crescendo, decrescendo. Crescendo, decrescendo, ejection murmur. Loudest at the heartbeat, radius to carotid. So only murmur at carotid. Okay. Yeah. In this, in the exam, they will give the point at the carotid area also. Carotid area में भी pulse आपको point देंगे. You have to take the mouth, you have to go and you have to hear it. Alright. तो अगर carotid area में आपको murmur सुनाई दे रहा है, definitely your answer is going to be aortic stenosis for sure. Okay. So pulses forward at tardus is important. Big pulses with delayed peak. These 2 points are important. The cases will always be presented to you with greater than 60 years of old. Patient will be greater than 60 years and there will be calcification. Okay. In young patient, it will be calcification of bicuspid aortic valve. Can lead to syncope, angina, dyspnea. Alright. So all these points very important. Only murmur with the carotid trill, aortic stenosis, crescendo decrescendo, pulses forward at tardus, greater than 60 years of age, with occurs in young, there is a calcification of bicuspid aortic valve. This question is there in UL. Okay, do this. And these are the symptoms. Alright, aortic stenosis done. Coming to mitral tricuspid regurgitation, the continuous murmur. It is going to be holosystolic, pansystolic continuous murmur. Okay, the holosystolic blowing murmur. If you have heard this, it will be like this. Tuk, 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 tuk. हार्टबीट के बीच में मरमर हो रहा है. ओके. MR loudest at the apex, radiate towards axilla. Okay. MR often due to ischemic heart disease, post MI, rheumatic fever में भी दिखता है. Alright. तो यहाँ पे they have given tricuspid regurgitation का भी often due to right ventricular dilation. Okay. That's it for mitral tricuspid regurgitation. इसमें ना they will ask you about they will give you the sound and you have to identify it. Blowing murmur. Alright. Moving to MVP, that is mitral valve prolapse. तो यहाँ पे क्या होगा? टिक 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 ओपनिंग मिड सिस्टोलिक क्लिक होगी यहाँ पे. सॉरी. ओके. लेट्स जस्ट सी. लेट क्रिसेंडो मर्मर विद मिड सिस्टोलिक क्लिक. Best heard over the apex, loudest before S2. Alright. Usually benign but can predispose to infective endocarditis, can be caused by rheumatic fever, caudal rupture. Myxomatous degeneration is very important. Myxomatous degeneration. Okay. Sudden tensing of caudate antenna as a mitral reflex prolapse into left atrium. This is very important. Alright. So mitral valve prolapse important hai. Do it properly. Myxomatous degeneration, connective tissue disease. Connective tissue disease can be Marfan or it can be Ehlers-Danlos disease. Okay. Ehlers-Danlos mein, that is hyperextensibility. Alright. Coming to last, VSD. VSD is holosystolic, harsh sounding murmur. Now see, mitral and tricuspid regurgitation are also holosystolic, and VSD is also holosystolic. But along with holosystolic, they will give you harsh sounding murmur. Harsh sounding murmur they will give you. Okay. So congenital है, large VSD are low intensity and smaller. Another thing, VSD का भी आपको लोकेशन देखना है. I think tricuspid पे होता है. Yeah. Alright, so you have to remember the location, you have to remember the maneuvers, you have to remember the features associated with each and every murmur. Okay, coming to the diastolic murmur, we have aortic regurgitation. मतलब ये आपको डिक 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 डिक, this is how you will be hearing it. Okay, mitral stenosis का कैसे होगा? डिक 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 opening snap. Okay, so you need to figure it out. सुन के ही पता लगेगा आपको. Alright, so this is also blowing murmur but it is diastolic murmur. ये भी blowing murmur है. Sorry, mitral and tricuspid regurgitation is also blowing murmur but it is up in systolic. And aortic regurgitation is. So I hope you are understanding the difference. Okay, ऐसे ही questions आएंगे. Alright, so what important is decrescendo, early diastolic. Another thing, बाइकस्पिड एओर्टिक वाल एंडोकार्डाइटिस, ये इंपॉर्टेंट है. वाइड पल्स प्रेशर, दिस इज इंपॉर्टेंट. वाइड पल्स प्रेशर इज वेरी इंपॉर्टेंट. हाइपरडायनामिक पल्स एंड हेड बॉबिंग, वेरी इंपॉर्टेंट. ओके, so this one word, अगर आपको कभी साउंड नहीं दिया, if you are not able to pick up from the sound, just look at the characteristics in the question and you are good to go. All right. Middle stenosis follows opening snap, delayed rumbling, mid to late murmur. Okay. Late and highly specific sequelae of rheumatic fever. Now see, rheumatic fever में late murmur is mitral stenosis, early murmur is mitral regurgitation. We'll be doing this earlier. Okay. Later we'll be doing this. Okay. Can result in LA dilatation, pulmonary congestion, atrial fibrillation, Ortner syndrome. LA dilatation है तो Ortner syndrome होना ही है. And what else? That's it. Okay. Coming to patent ductus arteriosus, it is a machine-like murmur. Okay. Intraclavicular area loudest at S2, often due to congenital rubella or prematurity. All right. So this is what about the murmur. Think about the sound. एक बार sounds का मैं summary दे देता हूँ आपको. Aortic stenosis, crescendo, decrescendo. Coming to mitral and tricuspid regurgitation. Okay. Coming to mitral valve prolapse. Mid systolic click. Ventricular septal defect. Continue होगा. Alright. Coming to diastolic में aortic regurgitation. Coming to mitral stenosis. Okay. And patent ductus arteriosus, it will be completely machinal. Alright. So murmurs very important है. और आपको मैन्युअल्स भी याद रखने हैं, आपको लोकेशन भी याद रखने हैं. मार्क माई वर्ड्स अगेन, यू वर्ल्ड में आपको बताते हैं, इन यू वर्ल्ड दे आर सेइंग इट इज एट ए, इट इज एट पी, इट इज एट टी, इट इज एट एम. एग्जाम वोंट से एट व्हाट लोकेशन इट इज प्रेजेंट. ऑलराइट. एग्जाम में आपको स्टेथोस्कोप दिया रहेगा वर्चुअल, यू हैव टू टेक दैट माउस कर्सर एंड देन यू हैव टू फाइंड आउट. ऑलराइट. सो दैट्स इट. वन इंपॉर्टेंट पॉइंट, यू वर्ल्ड में क्वेश्चन है, severity of mitral stenosis it depend on length of stenosis, not on intensity. Length of murmur, not on intensity of murmur. Okay, so ये याद रख लेना. You will make question. All right. I think we are done with murmur. Now let's go to another physiology, myocardial action potential. So myocardial action potential है. So you have to remember हर एक फेज में क्या हो रहा है, किस में सोडियम बढ़ रहा है, किस में पोटेशियम कम हो रहा है, किस में पोटेशियम बढ़ रहा है. Questions have been asked frequently. And one more thing, this is about the myocardial action potential, that is the myocytes में क्या हो रहा है. Okay, it is not about the SA node or AV node. Okay, pacemaker का अलग ग्राफ है, अलग फ्रैक्शन है. तो you have to remember कि दोनों के phase 1 phase 2 में what are the differences. All right, moving ahead. इलेक्ट्रोकार्डियोग्राम, ECG, अनदर हाई yield stuff. ECG भी आपको अच्छे से आना चाहिए. But in step 1, the ECG are very easy. Okay, you have to just be prepared and with all the ECGs given in UWorld and in the first aid, and you are good to go with the ECG question. All right. So इसमें वही है, ऐसे नोड, AV node कहाँ का location. Yeah, so many questions have been asked about the location. Okay, AV node located in the posterior inferior part. So many questions. Pacemaker rates, very important. Speed of conduction, very important. This is very important. So many questions have been asked, and in the exam I was asked about the speed of conduction, order of conduction. Okay, moving to the different waves and इसका meaning ये आप कर लेना. P wave, QR, TES क्या मतलब होता है. This is the basics of ECG. All right, so that's it. ये ECG के basics है. Now let's just discuss कि इसमें ECG नहीं दिया. एक मिनट रुको, ये एडिशन में ECG कहाँ है, पैथोलॉजी पार्ट में है क्या. या सो लेट्स जस्ट कैरी आउट द ECGs फर्स्ट. पहले ECGs कर लेते हैं सारे, सो दैट वो फिजियोलॉजी का टॉपिक खत्म हो जाएगा अपना. ऑलराइट, लेट्स जस्ट सी एट्रियल फिब्रिलेशन. एट्रियल फिब्रिलेशन. ऑलराइट, irregular regular rate. इरेगुलर रेगुलर और इरेगुलर इरेगुलर, अगर ये वर्ड आपको एक क्वेश्चन में दिखता है, आंसर इज एट्रियल फिब्रिलेशन. ओके. नो पी वेव्स, they will give you alcoholic patient. Okay. Binge alcoholic. And what else they can give you is holiday heart syndrome. दिया है क्या यहाँ पे holiday heart syndrome? नहीं दिया. देखो, holiday heart syndrome, that is what binge alcoholic. Like there was a holiday, the people decided to do booze and so much drinking continuously. एक साथ 15-20 ग्लास पी लिए अल्कोहल के कूल बनने के चक्कर में. एंड नेक्स्ट डे he is found either dead or he is not able to wake up, and the heart में rhythm perfect नहीं. Okay. So AR AF easily able to identify from the ECG strip. ठीक है. RI interval गड़बड़ है, P wave नहीं है. The main thing is you have to look for the P wave. You just can't look at RR interval. अगर RR interval नहीं है, P wave present है, तो कुछ और लफड़ा हो जाएगा. Alright. Coming to multifocal atrial tachycardia, this is the new ECG that they have added. Old ECG में ये added नहीं था. Okay. Irregular regular rate and rhythm with at least 3 distinct P wave morphology. मतलब यहाँ पे P wave present है, RI interval present नहीं है. तो you can remember like this: P present, RR variable. Okay. Let's go for the atrial flutter. Rapid succession of identical conjugative atrial depolarization, sawtooth pattern. RR interval equal है, sawtooth pattern दिख रहा है. All right. One important point, yeah, I forgot. This is very very important. UL में दिया हुआ है. Treat light atrial fibrillation catheter ablation of region between tricuspid NLS and IVC. In UL they have asked about the treatment also. Okay, here also if they are asking about the ablation, the definitive treatment is ablation of pulmonary vein ostia or left atrial appendage. This is very important. So many questions are there in UL. NBME ने भी 2-3 सवाल पूछे हैं. All right, so you should remember. And in the exam I got this ablation of atrial fibrillation where, so you have to remember this. Okay, याद कर लेना, बहुत important है. This is one update in the new edition. It is not given in the old edition. All right. Moving ahead, we have paroxysmal supraventricular tachycardia. Okay, PSVT जो बोलते हैं, I think इसको. Okay, most often due to re-entrant tract between atrium and ventricle. This is not very important, just ignore this. जितना याद रखो ये ECG का step. PSVT के बारे में they won't ask information. If they want to ask, they will ask you ECG step. Wolff Parkinson White syndrome, very high yield and very easy. आपको ECG में ध्यान से देखना है. Okay, ECG में ध्यान से देखो. The problem will be in the atrial flutter and Wolff Parkinson White, because you know दोनों में ऐसी स्ट्रिप देंगे ये लोग, ऐसी ऐसी ऐसी. बट यू हैव टू पिक आउट कि डेल्टा वेव दिख रही है कि नहीं. दिस इज व्हाट द डेल्टा वेव इज. ऑलराइट. द कॉमन टाइप ऑफ वेंट्रिकुलर प्री एक्साइटेशन सिंड्रोम, abnormal fast accessory conduction pathway from atria to ventricle, bypasses rate slowing AV node ventricle. ये सब important है. Everything is important. They have asked many questions one liners में, WPW में, और क्वेश्चन में ही दे दिया डेल्टा वेव दिख रही है. Now what will be the pathology over here, that you have to remember. Okay. So Wolff Parkinson White, delta wave ढूंढो, easy to go. Ventricular tachycardia ऐसे आएगी. कभी पूछा तो नहीं है, जस्ट डू दिस. यू वर्ल्ड ने पूछा है तो आपको याद रखो. टॉर्स एट द पॉइंट. इसमें सबसे पहले तो ड्रग याद कर लो. आप ड्रग याद कर लो एंड डायरेक्टली ऐसा आए. ओके, डायरेक्टली. अभी देखो, टॉर्स एट द पॉइंट and polymorphic ventricular tachycardia, one thing will be differentiated from ventricular fibrillation. Okay, in ventricular fibrillation, you know, there won't be like this. See, यहाँ पे ऐसे ventricular bigeminy भी दिखेगी. Okay, ऐसे ऐसे दिखेगी ऐसे. But in ventricular fibrillation you will never find that. Alright, कभी नहीं दिखेगा. But ये इसमें दिखता है. To make sure you know this. Another thing, caused by drug decrease in all this stuff. Okay, caused by drug which are caused by decrease in all this iron. All right, so ये याद रखना. ड्रग्स आपको याद रखना है. वेंट्रिकुलर फिब्रिलेशन, इसी स्टेप याद रखना. Now the main problem, the most difficult part about the ECG strip is the conduction pathology. Okay, conduction में first degree heart block, सेकेंड डिग्री में दो टाइप एंड थर्ड डिग्री में डिस्ट्रॉय. बंडल ब्रांच दे वोंट आस्क, तो टाइम पास नहीं करना है. कमिंग टू द फर्स्ट डिग्री हार्ट ब्लॉक, वी हैव प्रोलॉन्ग पीआर इंटरवल. प्रोलॉन्ग्ड पीआर इंटरवल, पीआर इंटरवल प्रोलॉन्ग्ड है सब. ओके. मोबिस टाइप 1, टाइप 2 में सेकेंड डिग्री में क्या है? प्रोग्रेसिव लेंथनिंग ऑफ पीआर इंटरवल अंटिल अ बीट इज ड्रॉप. प्रोग्रेसिव लेंथनिंग, हर एक बीट के बाद प्रोग्रेसिव लेंथनिंग ऑफ पीआर इंटरवल है. एंड देयर विल बी वन one beat will come where there will be no QRS. Okay, so this is important. Coming to type 2, drop beats that are not precipitated by the change in PI interval. मतलब PI interval same है, beat dropped. So what is the difference? First degree AV block में PI interval prolonged. Okay, that's it. यहाँ पे drip the beats are not dropped over here. Okay, coming to Mobis type 1, PR interval prolonged होते जा रहा है. Like after every beat PR interval का length बढ़ते जा रहा है. Length is increasing and there comes a time when the beat will be dropped. Absent QRS. Okay, coming to Mobis type 2, PR interval is same. Okay, but the beat is dropped. This is the difference between first degree and Mobis type 2. PR interval same रहेगा, but first degree में there won't be any drop in the beat, but in the Mobis type 2 there will be a drop in the beat. All right. Moving ahead, we have third degree में. Third degree में atrialization. The one word that you need to remember are atria and ventricles beat independently. It is causing atrialization of ventricles. Atrialization of ventricles. So this you need to remember. देख लो आप कितना P wave QRS पे attack है. This is one important feature. All right. This premature beats they have given in this new edition. They didn't give in the old edition. तो just एक बार ये देख लेना. Old edition में नहीं दिया है. It was just asked in the UL. It wasn't asked in the NBM. So just go through it. ये नहीं पूछेंगे वो लोग. This is all the ECG complex ECG are a part of step 2 CK. तो step 1 में इतने ज़्यादा माथाफोड़ी नहीं करनी है. Hereditary channelopathy, you have Brugada syndrome and congenital long QT syndrome. Brugada syndrome, autosomal dominant, and mostly it will be due to the mutation of sodium channels. All right. And congenital QT, mutations in this, loss of function mutation of potassium channels. So that's it. Yeah. इसमें ये बात रखना, Jervell and Lag-Nielsen syndrome, sensory neural deafness, and Romano-Ward syndrome, no deafness. So this is important. High yield. All right. Six sinus syndrome, UL ने पूछा है, but no question in NBME. So age-related degeneration of HA node. Okay, ECG can show bradycardia, etc. देख लो. Okay, UL ने पूछा है, NBME ने नहीं पूछा है. So I think we are done with the ECG over here. So coming back to where we left in the physiology. Okay, so ECG हो गया. Now let's do this. These two peptides are very important because what they will help you, the BNP will help you in measuring the heart failure. हार्ट फेलियर का डायग्नोसिस करने में बीएनपी इज वेरी हेल्पफुल. ऑलराइट. तो देखते हैं एएनपी, एट्रियल मायोसाइट एंड वेंट्रिकुलर मायोसाइट ड्यू टू टेंशन, ड्यू टू इंक्रीज इन ब्लड वॉल्यूम एंड एट्रियल प्रेशर. ऑलराइट. तो डिक्रीज इन सोडियम रीअब्जॉर्प्शन कराते हैं, डायलेट, ये सब आपने रेनल में देखे ही है. ओके, बट बीएनपी नहीं देखा है. बीएनपी ब्लड टेस्ट यूज्ड टू डायग्नोस. ऑलराइट. सो एएनपी बीएनपी डन. रिसेप्टर्स, बैरो रिसेप्टर्स एंड केमो रिसेप्टर्स, यहाँ आप बस इसको एक बार रीड कर लो. दीज आर नॉट वेरी हाई यील्ड. ओके, यूवर्ल्ड में है काफी सवाल, सो यू कैन जस्ट गो थ्रू देम, बट दे आर नॉट वेरी हाई यील्ड. तो यूवर्ल्ड में जो 3-4 सवाल है ना, उसको गो थ्रू कर लो. केमिकल रिसेप्टर्स और पेरिफेरल रिसेप्टर्स, ऑल दोस, जस्ट गो थ्रू दैट. नो नीड टू गो इनटू डिटेल दिस. यू कैन अवॉइड दिस आल्सो, बट यूवर्ल्ड में जो क्वेश्चन है एक बार गो थ्रू कर लेना. ओके, मूविंग अहेड. नॉर्मल रेस्टिंग कार्डियक प्रेशर रीड कर लो, नॉट नीडेड. याद करने डिफिकल्ट होगा. ओके, नाउ या दिस इज इंपॉर्टेंट. Autoregulation. How blood flow to an organ remains constant over a wide range of perfusion pressure. Lungs में hypoxia से vasoconstriction होगी. Heart, this metabolite. Brain, metabolite. Kidneys, myogenic and tubulogrammic feedback that we did this in the renal. I told you to refer BRB. BRB physiology. Okay. Skeletal muscle में, remember this. Skin में, it causes vasoconstriction. Alright. So pulmonary vasculature is unique in that alveolar hypoxia causes vasoconstriction so that only well ventilated areas are perfused. Okay. So this is very important. Auto regulation में सवाल आया है in exam also, in NBME also. Alright. Moving ahead. Capillary fluid exchange. This is also very important. What they have asked over here is they love to ask regarding the examples. They love to ask regarding the example. ये formula आप भूल सकते हो, but remember this parameters and remember the example. किसमें permeability increase है, किसमें oncotic pressure increase है, किसमें oncotic pressure decrease है. So remember these examples. You're good to go. If you are not able to apply the logic, if you are not able to understand the concept, examples याद कर लो. Good to go. For 100%, one or two questions will be coming from there. All right. So examples याद कर लो. You're good to go. All right. So pathology आ गया. Let's take a 5 minute break and then we'll finish pathology today. All right. Pharmacology and reproductive will start tomorrow. And I think Thursday तक class extend होगी. So कर लेंगे. So I think Thursday will be the last class. So let's take a 5 minute break and then we'll complete CBS pathology today. All right. All right, let's continue. Cardiac pathology. So congenital heart disease first topic, and congenital heart disease so frequently asked in the exam. So let's just do this. Right to left shunt first. So these are the five things you have to remember in right to left shunt. Early cyanosis, often diagnosed prenatally or become evident immediately after birth. Okay, early cyanosis is important, and yeah, this is important. Early cyanosis is important. आपको क्वेश्चन में डायरेक्ट पता चले जाएगा. In the question directly they will give you there was early cyanosis and the blue was seen as soon as the baby was the birth. Okay, baby was born. First one, persistent truncus arteriosus. Truncus arteriosus fails to divide into pulmonary trunk and aorta due to failure of aorta pulmonary. Most patients have accompanying VSD. Now see, what is this is कि you have to figure out कि ये right to left है या left to right है. Okay, and how you will be figuring out based on the cyanosis. Now, in right to left, there is a possibility that they are accompanied with VSD or ASD or PDA. Okay, PDA and VSD most commonly होते हैं, ASD काफी rare होता है. So you don't have to confuse कि ये early cyanosis है, how it can be VSD and something like that. Okay, VSD is accompanying that disorder. All right, so make sure you are thorough with this. So persistent truncus arteriosus, it is also associated with 22q deletion. Okay, ये याद रखना है आपको. Coming to the second, detransposition of great vessels. What happens here? Aorta leaves the right ventricle and pulmonary trunk leaves left ventricle. Normally it is ulta, or normally it is opposite. Okay, so separation of systemic and pulmonary circulation. Not compatible with life unless a shunt is present to allow mixing of blood. Now one thing, they will give you the diagnosis of TGA and then they will ask you what you should do. Your answer will be create a shunt, VSD, or your answer will be open, keep keep the shunt open, keep the VSD open. Only then there will be the mixing of blood and only then the circulation will occur and respiration will occur. Otherwise systemic अलग चल रहा है, pulmonary अलग चल रहा है, mixing कहाँ होगा? Oxygenated deoxygenated convert होगा ही नहीं. All right, so you have to think this VSD PDA जो भी है उसको open रखना है. You have to keep that open, don't have to treat that. Okay, this is also 22q. All right, and what else is due to failure of aortic or pulmonary septum to spiral. आपने देखा होगा हार्ट ट्यूब जो होती है वो स्पाइरल होती है, तो वन विल बी गोइंग आउट ऑफ एओर्टा एंड अदर विल बी गोइंग आउट ऑफ पल्मोनरी ट्रंक. तो यहाँ पे स्पाइरल नहीं हो रहा है, तो दिस इज इंपॉर्टेंट. स्पाइरल वर्ड इज इंपॉर्टेंट. ओके, coming to tricuspid atresia, absence of tricuspid valve and hypoplastic right ventricle. Now in the question they will give you right ventricle size has been decreased, hypoplastic. So tricuspid atresia. Coming to tetralogy of Fallot. So these two cases, transposition of great arteries and tetralogy of Fallot, they are very common. Very, very commonly. Okay. Caused by anterior superior displacement of infundibular septum, one important line. Pulmonary infundibular stenosis, second important point. Right ventricular hypertrophy, boot-shaped dart. Boot-shaped dart. Third important point. Overriding aorta and VSD is supposed to be present in almost all the conditions. Okay. So yeah, another important point over here. Squatting increases SVR, decrease in right to left shunt, improves cyanosis. Or this is also associated with 22q11. Now one more thing, is squatting से क्या होगा? In the question they will ask, what is the purpose of squatting? So you will answer increase in systemic venous resistance, that will decrease the shunt. It will improve cyanosis. Alright, so this is important. And yeah, another one is TET spells. TET spells, that is crying, fever and exercise due to exacerbation of right ventricular outflow. So each and every line in this congenital heart disorder is very important, and based on one word, you will be able to diagnose कौन सी condition है. Okay, TAPVR, total anomalous pulmonary venous return, ignore करो, कभी नहीं पूछते. Epstein anomaly, they can ask. The most common association of Epstein anomaly is lithium exposure. Okay, lithium we saw it in the psychiatry drugs में. So उसमें displacement of tricuspid valve reflect downward into RV, artificializing atrializing the ventricle. Atrialization of ventricle आया to Epstein anomaly, and in the history they are saying lithium exposure. That is important. So with this we are done with the right to left chain. Now moving to left to right chain, इसमें there will be late cyanosis. Okay, late cyanosis. Now frequency मतलब कि सबसे ज्यादा कौन सी दिखती है? VHD is most common, then AHD and then PDA. Okay, let's do AHD first. So VHD चलो कर लेते हैं. Asymptomatic at birth may manifest weeks later. ये सब resolve. Larger lesions may lead to LH. ये सब ठीक है, normal चीज है. O2 saturation increases in right ventricle and pulmonary artery. Now what does this mean? See, ये हार्ट के चेम्बर्स है. Okay, right atrium, left atrium, right ventricle, left ventricle. Okay, now ventricular septal defect है, so it means there is a defect over here. So blood can be flowing back to right ventricle, right atrium, left atrium. ऐसे कर सकता है. Left atrium तो नहीं, right atrium कर सकता है. So now you will have asked so many questions about the oxygen concentration. Okay, so we can say लेफ्ट वेंट्रिकल से राइट वेंट्रिकल में ब्लड जा रहा है. फ्रॉम ब्लड इज गोइंग फ्रॉम लेफ्ट वेंट्रिकल टू राइट वेंट्रिकल, so the oxygen concentration will also increase in right ventricle. Okay, it will also increase in right atrium, it will also increase in the pulmonary artery. So this is how you have to remember the oxygen value. All right, so ये आपको ऐसे याद रखनी है. Coming to atrial septal defect, so defect in interatrial septum. Fixed split. Fixed split is important. I know splitting we have ignored, but when they are asking about AHD, they use the word wide fixed split. So this is important. Ostium secundum defects most common and usually isolated finding. Ostium primum defects rare and usually occur with other cardiac anomaly. So most common is ostium secundum. All right. And the symptoms range from none to heart failure, distinct from patent foramen ovale, which is due to failed fusion. Okay, patent foramen ovale से अलग है ये. So O2 saturation increase in right atrium, right ventricle and pulmonary artery. यहाँ पे what is happening? This is the chamber, right atrium, left atrium, right ventricle, left ventricle. The problem is over here. So हो सकता है ना कि left atrium से blood जा रहा है right atrium में. Okay, now from right atrium the blood is going into right ventricle and then it will be going to the pulmonary trunk and everywhere. So oxygen concentration is also to be increased. Right, left atrium से right atrium में shift हुआ, right ventricle में shift हुआ. Okay, so you will have asked so many questions O2 concentration and even NBME has asked. Okay, I am showing you two images over here. See, this is about AHD. So you can see superior vena cava, right atrium, left atrium, right ventricle, left ventricle. Normally atrium में तो deoxygenated blood आता है, so oxygen concentration can't be that much more. Like they are saying कि direct jump हुआ 73% to 85. How is that possible? So 73%, it should be 73, it should be 73, and then the pulmonary system comes into play, and then the deoxygenated will be oxygenated, and then it will be going like that. All right. So यहाँ पे direct jump हुआ, it means कि लेफ्ट एट्रिया से ब्लड आया और लेफ्ट वेंट्रिकल से ब्लड आया. Alright, the questions have been asked like this, so make sure you know them. This is about VHD. No, this is not VHD. Yeah, this is about VHD. Alright, so 96% left ventricle, 85% left right ventricle, but in the right atrium it is 73%. Direct jump from right atrium to right ventricle. Okay, so you have to open your brain and you have to understand कि हाँ भाई इधर से इधर गया तो इसका बढ़ सकता है, ब्लड बढ़ सकता है. All right, so you have to think like this. Questions have been asked. All right, that's all for VHD. AHD, sorry. So AHD may be there is it is associated with Down syndrome. But while we were doing the Down syndrome, I told you you will mark neither AHD, you will not mark neither VHD. You will mark AVHD, that is atrioventricular septal defect. All right. Moving to PDA, patent ductus arteriosus. See, this is all about we did in the respiratory. Sorry, not respiratory, fetal circulation. So you have to keep this in mind. Okay. Now one more thing. It is a machine-like murmur. We discussed this earlier. The patency is maintained by PGE synthesis and low O2 tension. Uncorrected can eventually result in late cyanosis in lower extremity. This is important. Okay. So what important point you need to write down here is, yeah, it is maintained by PGE synthesis. So treatment also you can give alprostadil. इंडोमेटासिन तो देते ही है. All right. And what else you need to remember? Okay, that's it. Yeah, one important point is there. यहाँ पे नहीं दिया है, so you guys write it down. Normally, pulmonary blood flow, systemic blood flow. The ratio is 1:1. Okay, QP, QS. The ratio is 1:1. In shunts, the ratio is the QP by Q3 is greater than 1. QS, sorry. Okay, so ये याद रखना. इतना they haven't asked, but in one or two questions it was given. Coming to Eisenmenger syndrome, uncorrected left to right shunt, increase in pulmonary blood flow. Now, one thing that you need to remember here is causes late cyanosis, clubbing, and polycythemia. If these symptoms are given, then only you go for Eisenmenger syndrome. All right. Coarctation of aorta, most commonly asked. Okay. So one typical case that I want to give you for coarctation of aorta is BP different in अपर लिम्ब एंड लोअर लिम्ब. बीपी डिफरेंट. अगर ये आपको कहीं पे भी दिख रहा है, think about coarctation of aorta, nothing else. Okay, and in every question 99% they will give you this one. Another case was 6 month old plus strong radial pulse plus cold lower extremities. So this is also the case of coarctation of aorta. I don't know how, but NBME had this answer. All right. So let's just see important point. Aortic narrowing, insertion of ductus arteriosus, just not important. Bicuspid aortic valve is very important. Okay, this word. Bicuspid aortic valve is very important. Mark my word. Turner syndrome is very important. Hypertension in upper extremities are cold with weak delayed pulses. Brachiofemoral delay. With age, intercostal arteries enlarge due to collateral circulation. Arteries erode. Notch the appearance on CXR very important. Okay, so notch the appearance on CXR. BP different in upper limb and lower limb, and Turner syndrome, bicuspid aortic valve, and aortic narrowing of near the ductus artery. Okay, so this is all important. All right, moving ahead. Congenital cardiac defect abnormalities. Remember this, we have already discussed. 22q11, very important. Turner syndrome, that is bicuspid aortic valve coarctation. This you have to keep this in mind. Okay. Moving to hypertension. Hypertension is nothing you have to remember over here. Just remember the BP and just see what are the causes. Increasing cardiac output and resistance increase. String of beats appearance that you will be seeing. Urgency means greater than 180 by 120. Emergency means it will be more than 210. Okay, it is very emergency, and emergency is only when you will see there is some organ damage. In urgency, no organ damage. Okay, so organ damage can be anything. It can be brain, it can be eye, it can be kidney, anything. All right, so that's all for hypertension. Don't have to remember much. Okay, moving to hyperlipidemia sign. Just remember xanthomas. बाकी कुछ करने की जरूरत नहीं है. Remember xanthomas, and it is because of atherosclerosis and all that. Okay. Now doing arteriosclerosis. Hardening of arteries with arterial wall thickening and loss of elasticity. Very important. Hyaline and hyperplastic. This is hyaline. There is a deposition over here. And hyperplastic is, oh, sorry. Yeah, this is hyaline. Hyperplastic will give you like onion appearance. Okay. So thickening of walls and plasma protein leak. Onion skin is hypertension, proliferation of smooth muscle cells. Okay, arteriolosclerosis, done. Monckeberg sclerosis, pipestem appearance. They never asked this. Okay, never asked this. But once question was there in UWorld. So it is only occurring in the medium-sized arteries. Okay, so make sure you know this. बाकी ये arteriosclerosis ये important है. Hyalin and hyperplastic. All right. Coming to cholesterol emboli syndrome, this is a new thing. Let's just see what is given here. Microembolization of cholesterol displaced from atherosclerotic plaque in large arteries results in end organ damage due to emboli. Okay, so basically emboli hai. So just think about it. All right. Moving ahead, atherosclerosis very highly. All right. So first of all, what you need to think is you have to remember the order. Now they will ask you, they will give you the atherosclerosis theme. And the second question will be, they will ask you which is the most common location for atherosclerosis to occur. So your answer, you have to follow this. If all the options are present, you know what is the priority. You have to give that. Okay. Risk factors, hypertension, tobacco, dyslipidemia, these are the common things. Symptoms, it can become angina, claudication, anything. Progression. Now this is where you will be remembering. Inflammation important in pathogenesis. This pathogenesis is very important. Give me a minute. Endothelial cell dysfunction, macrophage and LDL accumulation, foam cell formation, fatty streak, smooth muscle migration, proliferation, fibrous plaque formation, calcification. So this entire four lines are very important. Okay, look at the images and I think you are good to go. Let me just see anything extra is there or not. Nothing. Just remember you were like given many questions regarding the pathogenesis in the pathophysiology section of CVS. Okay, so make sure you know that. Coming to aortic aneurysm, another very high yield, so frequently asked. Let's just see pathologic dilation of aorta. So symptoms will be abdominal back pain, which is a sign of leaking, dissection or imminent rupture. तो abdominal back pain की बहुत सारे लोगों बहुत सारी फीचर्स के साथ आता है, डिजीज के साथ आता है. ओके, तो एन्यूरिज्म भी याद रखना है. लेट्स जस्ट सी फर्स्ट thoracic aortic aneurysm. Cystic medial degeneration, hypertension is the most common, also associated with syphilis. Aortic root dilation may lead to aortic regurgitation. Okay. So thoracic aortic regurgitation is not important. But what is important here is you have to remember this line. Cystic medial degeneration is very important. Okay, cystic medial degeneration very important, and they will give you thorax में हुआ है ऐसा वैसा. Okay, coming to abdominal, this is very important. First of all, you need to remember this CT image. Okay, this CT image you have to remember. Another thing, associated with transmural, all three layers of inflammation and extracellular matrix degeneration is the first point. Risk factors में tobacco use is very important. यहाँ पे hypertension, यहाँ पे tobacco use. Okay, may present as a palpable pulsatile abdominal mass. Pulsatile abdominal mass will be there. Rupture may lead to triad of pulsatile abdominal mass, abdominal pain, resistance, hypotension. Okay, most often infrarenal. So abdominal aortic aneurysm is more important than thoracic one. Thoracic one may you just have to remember cystic medial degeneration and hypertension, whereas in abdominal you have to remember tobacco use, abdominal pain with pulsatile abdominal mass. All right. Moving to traumatic aortic rupture. So let's just see. Due to trauma or deceleration injury, commonly at aortic isthmus. Aortic isthmus is proximal descending aorta. In UL, they have given one question, they have drawn the diagram and then they have asked. So mostly the answer is here. Okay, मतलब this is not the answer यहाँ पे, but I am saying कि UL में ऐसे बना के देंगे and your answer will be near the isthmus, proximal descending aorta. All right. So let's just see aortic dissection. First of all, remember this image. Okay, this and aneurysm ka image you should be able to distinguish. Now let's just see the information. Longitudinal intimal tear है यहाँ पे. Okay, as well as hypertension, all this stuff can present with tearing, sudden onset chest pain radiating to the back, markedly equal BP in arm. Now see, equal BP in arm It can be dissection also and coarctation of aorta also. But 99% NBME and UL in step 1 have focused on coarctation of aorta. They have not focused on dissection. Okay, so this also you need to keep this in mind. CXR shows mediastinal widening. This is important. Can result in organ ischemia, rupture, death, anything. Stanford type A, Stanford type B, they have not mostly asked this, so you can actually avoid this. It is extra information. You will make सवाल होगा, but you can avoid this. NBME hasn't asked this. Just remember the image. Just remember intimal tear. Just remember the BP unequal हो सकता है again, and CXR shows medial channel widening. All right. Subclavian steal syndrome. Okay. Now one important point. I am going to write it down for you. Subclavian steal syndrome and vertebral artery syndrome. अगेन अनदर थिंग, इन दोनों के बीच में अगर आपको डिफरेंस जानना है, तो अगेन यार बीपी अनइक्वल, यहाँ पे बीपी विल बी नॉर्मल इन बोथ और सेम, डिजीनेस होगा, डिजीनेस यहाँ पे भी होगा, बट यू हैव टू लुक एट द बीपी. अगर इफ इट इज अनइक्वल देन योर आंसर विल बी सबक्लेवियन स्टिल, इफ बीपी इज नॉर्मल देन वर्टिब्रल. बाकी सारे प्रेजेंटेशन इट विल बी सिमिलर टू द सबक्लेवियन. देयर विल बी द फेशियल स्वेलिंग एंड ऑल दोस स्टफ, एवरीथिंग विल बी देयर. All right. So make sure you know the difference between subclavian seal and vertebral artery. Now coming to angina. Okay, angina, stable, vasospastic and unstable. You should be knowing. So उससे पहले let's just see differences क्या दिए हुए. ECG changes आपको आने चाहिए. Infarction, subendocardial and transmural you should be knowing. Pain on exertion, mild or rest. No elevation, no elevation, elevated, elevated. So semi is a case of myocardial infarction, so you won't be considering that over here. But let's just see यहाँ पे क्या हो रहा है. Stable angina due to atherosclerosis, 70% occlusion. External chest pain in classic distribution. ST depression, resolving with nitroglycerin. This is very important. If in the question they are saying कि the patient is walking and he is getting chest pain suddenly, okay, the treatment you will be giving nitroglycerin, that is sublingual nitroglycerin. This is the most commonly asked question. Vasospastic, fringe metal occurs at rest, secondary to coronary artery spasm, transient ST elevation. Tobacco smoking is a risk factor. Hypertension and hypercholesterolemia are not. Okay, so यहाँ पे treatment will be calcium channel blocker, nitrates and smoking cessation. Coming to unstable, thrombosis with incomplete coronary artery occlusion, ST depression, T wave inversion, but no cardio biomarker. Okay, so unstable से अगर treat नहीं हुआ, so it can go towards MI, but stable and vasospastic you have to remember stable, atherosclerosis and nitrate. Okay, so this is the difference you have to remember. Coronary steal syndrome. Distal to coronary stenosis, vessels are maximally dilated at baseline. Administration of vasodilators dilates normal vessels. Blood is shunted towards the well-perfused area. Now, this line is very important because this is asked in UL. They will give you a condition and then they will say कि vasodilators were given and then as a result, the blood flow shunted to the well-perfused area. Okay, so this is very important. Coronary steal syndrome. Sudden cardiac death. Sudden cardiac death. Death occurs within 1 hour of symptoms, most commonly due to little arrhythmia. It can be ventricular fibrillation. All right. 1 hour में death हो रही है, sudden cardiac death. Chronic ischemic heart disease. So first thing you have to remember here, this is given in new world, so this is updated in the new edition. It isn't given in the old edition. Myocardial hibernation and myocardial stunning. Potentially reversible. Remember this. Okay, ये याद ही कर लो. New world में दिया हुआ है. I think 3 to 4 questions are there. All right. Myocardial infarction, non-semi and semi. The first diagnostic markers of myocardial infarction are this CKMB and troponin. After this, you will be looking at the ECG strip. Okay, so non-semi में subendocardial, semi में पूरा transmural. Okay, and ECG changes ST segment depression, here ST segment elevation, pathology Q wave. It is a distinct and semi or semi. All right, moving ahead. Now mark this as very high yield. Just you remember in CNS we used to study in the ischemic brain disease. We used to study about what will happen after 12 to 24 hours, after 24 to 36 hours, and everything. We used to remember that. Same you have to remember in MI. Okay, MI में भी same चीज remember करनी है. They will give you 1 to 3 days, 3 to 14 days, 2 weeks to several months, and you have to remember the pathological features. Alright, pathological features याद करनी है आपको. Macrophages कब दिखेंगे, neutrophils कब दिखेंगे. Okay, and in exam I got this, and NBME has so many, even UL has asked so many questions, so this is very high yield. Remember the time period, 1 to 3 days में there will be neutrophils, 3 to 14 days में there will be macrophages. Remember this diagram also, remember this slide also. Okay, another thing, 0 to 24 hours में आपको दिखेंगी eosinophils, dark eosinophils. It will be causing dark mottling. Okay, so all these small things are very important, so make sure you know them. Now along with this, before doing this page, let's just move towards uh, this page. Yeah, this page, myocardial infarction complications. We will come back there, but पहले ये देख लेते हैं. What is important over here is they will give you key time, first few days to several weeks, 1 to 3 days, 2 to 7 days, 3 to 5 days. This all is important, and you have to remember कौन सी condition कब होती है. You have to remember, you don't have any option. All right, so ये याद रखना, एटलीस्ट ये कंडीशंस और टाइम याद रखना. बाकी if you don't understand this, it's okay. Okay, if you don't understand this, it's okay, but in this edition they have increased the information, so I'm sorry मैंने पहले क्रॉस करवाया. Let's just see कि what extra information they have given over here. So arrhythmia due to myocardial death starting. Now see, most common cause of death after myocardial infarction is arrhythmia. Most probable arrhythmia, ventricular or supraventricular. Okay, and arrhythmia is most common. Most common cause of death after MI, or you can say lightning arrhythmia. Okay, coming to peri-infarction pericarditis, self-limited होती है. Papillary muscle rupture, very important. Posteromedial more common. Okay, posteromedial has single blood supply, whereas anterior has dual. We saw this. I made you write it down. So this is important. Intraventricular septal rupture, so there will be VSD. Okay. Ventricular pseudoaneurysm, free wall rupture contained by adherent pericardium or scar tissue. Okay. Ventricular free wall rupture. Free wall rupture में यहाँ पे होगा cardiac tamponade. If there is a free wall rupture, they are talking about cardiac tamponade. True ventricular aneurysm, no need. Post cardiac injury syndrome, it's okay. Fibrous pericarditis, there will be Dressler syndrome. इसमें pericarditis होती है. Okay, so remember one thing, if there is a free wall rupture, there is cardiac tamponade. Coming back to this page, see here also, free wall rupture is tamponade, papillary muscle rupture is mitral regurgitation, interventricular segmental rupture due to this left to right shunt. This point is very high yield. You should be knowing about the region of complication. Free wall rupture हुआ तो tamponade, papillary muscle rupture हुआ तो MR. Okay, please remember this, very high yield. Okay, so अभी diagnosis पे आ जाते हैं. Diagnosis में कुछ नहीं करना है, just remember CKMB and troponin 1. बस इतना याद रख लो, you will be good to go for diagnosis. Coming to ECG localization of STEMI. Now remember this by heart, this table. By heart this table. This is going to help you a lot, and they will give you the leads, and you will have to find out which artery is associated and what is the location of infarct. Okay, most commonly asked, very easy, बस याद रख लो. Pathology is very easy in CVS, very easy. The only problem was in the physio and pathophysio. Okay, we have done this arrhythmia, we are done with MI, we are done with congenital heart disease. कि treatment they never ask, तो इसको पढ़ो ही मत, ignore करो. Now the next topic is cardiomyopathy, heart failure. We have shock, tamponade, endocarditis, rheumatic fever, pericarditis. Let's complete it. Okay, complete कर लेते हैं. Okay guys, let's do one thing. Heart failure से कल कर लेंगे. I'm tired. I have to report to hospital tomorrow morning early. So cardiomyopathy कर लेते हैं. Heart failure से कल कर लेंगे because it is going to take 40 minutes more, and I have to wake up early tomorrow to go to hospital. So dilated cardiomyopathy तक करते हैं. Sorry, cardiomyopathy कर लेते हैं. DCM, HCM, RCM. First of all, we'll take. Okay. Most common cardiomyopathy, often idiopathic or familial, mutation of TTN gene. Very important. TTN. Etiologies में alcohol very important and drugs very important. Alcohol, cocaine and doxorubicin. We have seen this in the anti-tumor drug in the hematology section. Okay. Chawas disease, dilated cardiomyopathy very important. Okay. और बाकी सारी कंडीशन से आप देख सकते हो. फाइंडिंग में आपको देखनी है हार्ट फेलियर, third heart sound, and it is systolic regurgitant murmur, dilated heart on echocardiogram, balloon appearance of heart on CXR. अभी HCM में डिफरेंस देखते हैं. Familial autosomal dominant, most commonly due to mutations in genes encoding sarcomeric proteins such as myosin binding protein C and this. Okay, this is important. Causes syncope during exercise and may lead to sudden death. Young athletes due to ventricular arrhythmia. Now, as nowadays we are seeing the people in gym, they are getting heart attack suddenly and they die. Okay, so they will in the question also they will give you gym patients or athletes, young athletes. Okay, यहाँ पे findings S4 systolic murmur may see mitral regurgitation due to impaired mitral valve closure. Okay, तो ट्रीटमेंट वही है. एथलेटिक्स को कम करना है, बीटा ब्लॉकर और NDHP. ओके, यहाँ पे ट्रीटमेंट इज मोस्ट इंपॉर्टेंट इज हार्ट ट्रांसप्लांट एंड वी कैन गिव ऑल दिस फॉर सोडियम रेस्ट्रिक्ट करना रहता है. सोडियम रेस्ट्रिक्शन इज इंपॉर्टेंट. Okay, so ये हमने पढ़ लिए causes and risk factors and findings. Now let's come to the pathophysiology. Pathophysiology, this is systolic dysfunction, this is diastolic dysfunction. Okay, displays eccentric hypertrophy, it will display concentric hypertrophy, and LV and RV enlargement facilitates increasing stroke volume and increasing cardiac output. यहाँ पे there will be myofibrillar dysuria and fibrosis. This is very important. बहुत सही जगह पूछा हुआ है. Okay, so here there will be stress cardiomyopathy. Stress cardiomyopathy is known as Takotsubo myopathy. तो यहाँ पे क्या होता है, broken heart syndrome है, ventricular apical ballooning due to sympathetic stimulation. So if in the question they say increase in concentration of catecholamines अगर देते हैं एग्जाम में, then think about Takotsubo cardiomyopathy. All right. Now coming to this, classified as hypertrophic obstructive cardiomyopathy when left ventricular outflow tract is obstructed. HOCM. We give the term HOCM. Okay. Symmetric septal hypertrophy and systolic entry and motion of mitral valve, outflow obstruction, dyspnea, possible syncope. Guys, this pathophysiology is very important. HOCM का pathophysiology है. Mitral valve will be coming anterior and it will be obstructing the outflow tract. Okay, so this is how you have to remember the images, very important. Now apart from this, there are few important things that you need to remember. I will write it down for you. Normal ejection fraction, normal, okay, wait, one thing, normal or decrease in LV EDP, left sorry, volume, left ventricular and diastolic volume, and what was that, increase in left ventricular and diastolic pressure. Okay, whereas in DCM, decrease in ejection fraction, increase in LV EDV, and increase in LV EDP. Okay, now one more thing I forgot, along with DCM you need to remember peripartum DCM. Okay, if the case over here is pregnant female plus edema plus heart problem, think about peripartum dilated cardiomyopathy, commonly asked in UL. Okay, now coming to restrictive cardiomyopathy, just remember one thing, Loeffler endocarditis, endocardial fibrous elastic tissue, and amyloidosis, sarcoidosis. So there will be some chronic disease over here. Okay, so diastolic dysfunction here also, can have low voltage ECG despite thick myocardium. Now you have to remember what is Lafleur endocarditis associated with hypereosinophilic syndrome. Histology shows eosinophilic infiltrate in myocardium. So this is important over here. Okay, and that's it. I think we will end today's class over here. It's so big. I tried to finish 50% of the pathology here, but tomorrow we will be finishing CVS along with pharma, and I think I'll finish reproductive physiology tomorrow. Reproductive pathology we will do on Thursday. So Thursday will be your last class, and that's it for tomorrow today's class. I think physio काफी clear हो गया होगा. I have explained you many parameters. पैथो में भी मैंने बता दिया कैसे क्वेश्चंस आते हैं. पैथो is going to be very easy. All right. So that's it for today. Tomorrow same timing, CVS complete and reproductive physiology will be doing. Okay. Yeah, that's it. Class is over. You can leave.